And also Professor Nat Lenzo, please give an applause for him. And I'm confident you will leave here with new insight and skill. Thank you for joining us, and I hope you have an engaging and educational experience. Let's get started. Okay, for the first sessions will be presented by United Imaging Healthcare, and they will talk about their technologies. Please, time is yours.
Mungkin Bapak dan Ibu dokter masih belum tahu saya, izinkan saya memperkenalkan diri saya terlebih dahulu. Nama saya Wahyu Trinugroho Adi. Saat ini saya sebagai Product Sales Eksekutif untuk Molecular Imaging. Dan saya sendiri beserta tim kami dari United Imaging Indonesia sendiri, kami sudah ada di Indonesia dari secara entity dari September 2023. Tapi kami masuk di Indonesia melalui distributor kami dari 2019. Artinya secara keseluruhan kami ada di Indonesia saat ini sudah kurang lebih adalah 5 sampai dengan 6 tahun, dan kami juga sudah mempunyai beberapa install base yang mungkin nanti kami coba paparkan di sini. Mungkin saya sedikit minta waktu 3 menit untuk tahu seperti apa United Imaging Healthcare melalui video yang akan saya paparkan. Ya, jadi dari 3 menit video yang tadi ditampilkan, pada dasarnya adalah United Imaging sendiri adalah merupakan grup. Jadi di bawah United Imaging itu ada 6 perusahaan, yang salah satunya adalah UII atau United Imaging Intelligence. Di mana United Imaging Intelligence ini merupakan perusahaan medical AI terbesar yang saat ini ada, karena memang kita dedicated karyawannya itu hanya untuk melakukan riset terhadap AI. Yang dimana ini menghasilkan seluruh dari modalitas kami. Tentunya untuk PET-CT kami di-assist oleh artificial intelligence. Jadi dari mulai pasien tiduran untuk positioning, kemudian penentuan area scanning, kemudian nanti direkonstruksi, itu sudah di-assist oleh artificial intelligence. Dan kita satu-satunya vendor yang mempunyai deep learning reconstruction untuk PET-CT, kita sebutnya adalah HyperDPR, yang mampu menurunkan dosis radioisotop ke pasien, yang disuntikan ke pasien, ataupun bisa mengurangi waktu akuisisi untuk PET-CT itu sendiri. Oke, jadi semua yang artificial intelligence ini kami ada di keseluruhan dari modalitas kami, karena kami tidak hanya berfokus ke molecular imaging, tapi kami sangat percaya diri bahwa United Imaging ini untuk molecular imaging saat ini adalah leading untuk digital PET-CT, karena di seluruh dunia kami sudah install kurang lebih adalah 600 unit PET-CT, dan kami market leader di beberapa negara untuk digital PET-CT serta small axial field of view. Oke, software yang ada di di UIA kami adalah salah satunya kami mendevelop software untuk MRI, CT, PET-CT, baik itu dari mulai rekonstruksi sampai dengan ke post processing. Kemudian kami juga punya radioterapi, dan juga kami juga punya TPS untuk radioterapi. Oke. Dan saat ini untuk software yang tersedia sudah lebih dari 100 software yang terintegrasi dengan artificial intelligence. Salah satunya adalah seperti untuk CT, kemudian ada PET-CT untuk oncology, itu juga sudah terintegrasi dengan artificial intelligence. Oke. Nah, saya masuk ke dalam United Imaging Intelligence, di mana yang sempat tadi saya bilang bahwa United Imaging Intelligence adalah United Imaging adalah satu-satunya perusahaan yang memang punya perusahaan sendiri khusus untuk mendevelop artificial intelligence, baik itu di modalitasnya sendiri atau di main unitnya ataupun di post processingnya. Nah, Nanti siang dokter akan berhadapan dengan post processing dari United Imaging Intelligence, di mana yang nanti dokter akan hadapi adalah di situ mampu melakukan lesi segmentasi secara otomatis, kemudian memberikan rekomendasi reporting, menentukan area lesinya di mana, semuanya bisa dilihat langsung di hasilnya. Oke. Ini untuk Global Office untuk United Imaging Intelligence, di mana secara headquarter sendiri kami ada di Shanghai, tapi untuk UII kita juga punya brand office di Beijing, Wuhan, Chengdu, Shenzhen, dan Xi'an. Kemudian di US sendiri kita ada di Boston. Oke, yang dimana hasil dari UII ini kita sudah mendevelop kurang lebih adalah 60 aplikasi yang terintegrasi semuanya dengan artificial intelligence, baik itu dari mulai organ kepala, jantung, kemudian paru, kemudian untuk onkologi tentunya, ini sangat penting untuk dokter-dokter spesialis kedokteran nuklir, kita juga ada di dalamnya. Oke, di mana untuk PET CT sendiri kita punya PET CT onkologi yang ini kita sudah dapat CE mark, di mana pada dasarnya kita mensupport dual modality lesion detection. Jadi baik itu PET dan juga kelainan yang ada di gambaran CT itu bisa terdeteksi secara otomatis. Yang artinya apa? Ini bisa memberikan efisiensi waktu dokter untuk melakukan reporting. Yang mungkin dalam satu hari dokter membaca itu misal 20 pasien, tapi dengan bantuan artificial intelligence mungkin dokter bisa membaca 40 pasien ataupun 50 pasien, seperti itu. Oke, dan secara otomatis juga nanti akan mengkalkulasi metabolic parameternya dari organ yang sudah terdeteksi secara otomatis oleh alat. Kemudian secara real time itu bisa menglokalisir area misal seperti vertebrae, kemudian misal contoh ada cervical, ribs dan lain-lain, itu bisa secara otomatis juga disegmentasi. Kemudian ini adalah untuk PET CT onkologi juga, aplikasi ini memungkinkan untuk registrasi follow up. Jadi kalau misal dokter punya pasien scan misal 6 bulan yang lalu, kemudian pasien datang lagi untuk scan, dia bisa follow up secara otomatis dan memberikan rekomendasi kelainan yang ada di misal di scan yang baru. Nah, setelah ini dokter hanya tinggal klik screenshot ataupun di follow up di sini. Ya, setelah itu di screenshot, maka secara otomatis dia akan memberikan interpretasi hasil yang saat ini ada seperti apa. Ternyata di sini ditemukan new abnormal radioactive uptake di area jantung. Kalau misal dokter merasa ini adalah betul, dokter tinggal confirm, maka nanti hasilnya akan masuk ke report. Nanti saya juga akan kasih seperti apa gambaran reportnya. Kemudian untuk automatic registration ini kita juga bisa juga untuk delay imaging, dan juga kalau misal nanti pasien dokter mempunyai different tracer, kita bisa juga melakukan registrasi ataupun follow up secara otomatis. Oke, ini adalah contoh gambaran untuk treatment response assessment untuk pasien limfoma dan juga solid tumor. Jadi secara otomatis sistem akan memberikan rekomendasi yang sudah ditemukan oleh alat, kemudian nanti dokter bisa tentukan Duvel scale-nya seperti apa, untuk kemudian menentukan lymphoma staging-nya seperti apa, nanti bisa terdeteksi secara otomatis, seperti itu. Dan untuk solid tumor pun juga sama, solid tumor pun nanti secara otomatis dia bisa mendeteksi dan dia bisa support untuk persis dan juga resist di sini. Jadi hasil ini dokter tinggal konfirmasi saja betul atau tidaknya. Kalau misal sudah dirasa betul, dokter tinggal screenshot, maka nanti di reporting akan muncul semua hasil dari automatic segmentasinya. Oke, kemudian kita juga mendukung untuk dual screen dan juga multimodality reporting. Jadi kalau misal biasanya dokter terbiasa di sini untuk melihat gambarnya, kemudian di sini langsung muncul rekomendasi kelainannya apa, nanti bisa langsung masuk ke report secara otomatis. Oke, ini contoh untuk automatic reporting dengan automatic description. Ya. Jadi PET-CT akan mendeteksi abnormal uptake detection di sini, kemudian di area CT-nya juga dia akan mendeteksi lesi secara otomatis. Setelah itu menginfokan juga lesi infonya seperti apa, baik itu size-nya, kemudian SUV-nya, kemudian area dari lesinya di area mana secara otomatis. Kemudian tinggal klik screenshot, maka nanti akan muncul reportnya secara otomatis. Oke. Dan kita juga mendukung untuk 20 anatomical plan dan juga untuk layoutnya kita juga bisa mendukung kurang lebih adalah 10 color schema untuk layout baik itu di reporting ataupun nanti di viewernya. Oke. Sorry Mas, boleh di ini videonya. Oke, ini adalah sedikit workflow seperti apa sebenarnya UII. Jadi pada dasarnya pendeteksian otomatis itu dokter juga bisa compare, kemudian nanti juga bisa men-generate reporting secara otomatis. Oke, sistem akan otomatis merekomendasikan kelainannya. Dokter tinggal confirm apakah itu betul atau tidaknya. Dan untuk ribs juga kita sudah automatic labeling. Ribs, kemudian spine, automatic labeling. Ini untuk yang follow up case. Jadi dokter bisa melihat secara bersebelahan yang sebelum dan juga pada saat ini di scan. Dokter tinggal confirm aja, nanti akan muncul report secara otomatis. Jadi report itu nggak cuma teks, tapi juga dalam bentuk gambar. Jadi yang biasanya dokter harus milihin gambar satu persatu, kalau di UI ini dokter tinggal screenshot, maka gambarnya langsung akan masuk ke report secara otomatis. Oke, ini contoh untuk reporting assisted untuk dokter. Jadi secara lengkap di sini disampaikan bahwa medical history-nya yang sempat misal dari admin sudah input, nanti akan langsung muncul di report dokter tanpa dokter harus mengetik ulang. Kemudian kelainan apa saja yang ditampilkan, itu juga dokter nggak perlu ngetik ulang misal ukurannya seperti apa, kemudian areanya di mana, dokter nggak perlu ngetik ulang karena kalau dokter udah confirm di awal, nanti akan langsung muncul di sini. Kemudian di impressionnya, syairnya pun kita juga bisa mengenerate berdasarkan artificial intelligence. Yang misal dokter udah punya template syair sebelumnya, kemudian dokter juga ingin menggunakan syair tersebut juga masih bisa kita submit ke reporting kita. Dan ini sifatnya adalah dia terus belajar, jadi dia akan menyesuaikan style dari reporting dokter, dari impression dokter seperti apa, nanti dia bisa menyesuaikan secara otomatis. Oke, nah ini contoh untuk reportingnya, jadi nanti akan muncul seperti ini dok, di atas itu adalah untuk clinical history-nya, kemudian ini adalah temuan dari sistemnya seperti apa, kemudian untuk impression-nya dokter tinggal klik AI di sini, maka impression akan muncul secara otomatis. Setelah itu kalau misal dokter membutuhkan untuk send ke PACS, dokter tinggal klik di sini preview ataupun approve, maka datanya akan terkirim langsung ke PACS. Jadi yang tadinya mungkin dokter baca satu foto sekitar 10 sampai dengan 15 menit, dengan bantuan artificial intelligence itu bisa kurang dari 5 menit. Oke. Ini bukan untuk menggantikan dokter, ini adalah untuk membantu dokter. Dan sekarang ini kita harus mengikuti perkembangan artificial intelligence, karena semakin kita mengikuti maka kita bisa semakin efisien, kemudian berguna untuk pasien kita dan lain-lainnya. Oke, kemudian untuk kolaborasi sendiri, kami sudah hampir di berbagai benua. Dan di Indonesia sendiri salah satunya adalah kami sudah berkolaborasi dengan Darmais dan juga Harapan Kita. Darmais kebetulan satu fokus di PET-CT dan juga satu fokus di mamografi. Kemudian di Harapan Kita coba fokus untuk ke area jantung. Kemudian di Cipto Mangunkusumo juga kita sudah berkolaborasi untuk brain segmentasi untuk gambaran MR. Jadi kolaborasi kita tidak cuma terbatas pada satu departemen, tapi kita bisa berkolaborasi dengan berbagai departemen nantinya. Karena tujuan kita kenapa melakukan kolaborasi ini adalah agar dokter-dokter di Indonesia bisa menyampaikan pikiran-pikirannya melalui jurnal, melalui paper yang mungkin nanti bisa dirujuk oleh negara lain. Karena selama ini kita merujuk dari negara luar. Padahal kita punya kemampuan untuk bahwa kita sebagai rujukan dari negara luar. Jadi kenapa kami melakukan banyak kolaborasi adalah biar Indonesia itu mengeluarkan banyak lagi referensi-referensi yang bisa dirujuk oleh negara luar. Oke, kemudian ini untuk inovasinya yang UII sudah lakukan. Jadi saat ini kita patennya lebih dari 300 paten, kemudian submit sudah lebih dari 800, dengan total citasi saat ini di 200.000. Jadi ini beberapa jurnal yang sudah kita keluarkan. Oke, nah secara struktur perusahaan di United Imaging Indonesia sendiri, mungkin ada beberapa dokter yang baru lihat tim kami ya dok ya. Jadi United Imaging Indonesia sendiri secara Indonesianya itu adalah kita baru lahir dok di September 2023. Memang secara tahun mungkin kita masih anak-anak yang masih belajar untuk berbicara. Tapi kalau dokter bisa lihat struktur dari perusahaan Indonesia sendiri, kami sudah punya tim yang sangat lengkap. Kami coba untuk bisa melayani customer kami di Indonesia itu dengan service sebaik mungkin dok. Karena tim kami sudah sangat lengkap. Di sales kami punya 3 sales di sini. Kemudian untuk tim produknya kami kurang lebih ada 6 orang produk. Dan untuk engineer, di mana ini posisi yang paling penting untuk rumah sakit mempertimbangkan kami sebagai partner adalah kami juga sudah mempunyai 5 engineer saat ini yang dedicated di United Imaging Indonesia. Tapi kami juga berbisnis di Indonesia itu dengan distributor kami, yaitu saat ini kami salah satunya adalah Divi Medica sebagai distributor kami. Di Divi Medica sendiri adalah mereka invest untuk mempunyai 20 engineer. Artinya support kami sebetulnya sudah sangat cukup, tapi kami tidak berhenti di sini aja, karena di tahun 2025 ini kami mencoba untuk hire lebih, terkhusus untuk teknisi, karena itu hal yang sangat penting untuk kami sebagai vendor untuk bisa tetap berjalan secara lama di Indonesia market ini. Oke. Kemudian ini adalah install base kami. Jadi dari mulai 2019 dengan Divi, kemudian United Imaging Indonesia masuk di September 2023, kami kurang lebih sudah punya 60 install base dengan rata-rata uptime-nya di 95%. Artinya apa di sini? Kenapa saya highlight uptime-nya 95%? Artinya sistem kami itu cukup awet ataupun tahan banting seperti itu. Karena memang pada dasarnya sistem yang dibuat oleh United Imaging itu melihat dari market di China. Dokter tahu populasi di sana sangat banyak, pasien per hari sangat banyak, dan untuk bisa settle di market China kita perlu alat yang awet. Bahkan untuk kita bicara misal CT scan, alat kami dipakai 200 pasien per hari. PET CT alat kami dipakai sekitar 60 pasien per hari tanpa ada kendala. Kemudian untuk alat yang akan terinstal lagi di Indonesia saat ini kami kebetulan dapat beberapa order ya. Jadi kami saat ini tahun ini akan install 3 CT Linac radioterapi. Kemudian tahun depan mungkin tempat mainnya Dr. Ruti di EK, kita akan install total body PET CT. Jadi PET CT yang panjangnya itu 194 cm, kemungkinan akan ada di tahun depan. Kemudian kita juga ada instalasi untuk ultra widebore MRI. Kemudian CAT lab kami juga sudah terinstal di beberapa rumah sakit besar, salah satunya ada di Gatot Subroto. Kemudian kita akan install PET CT 2, kebetulan satu sudah terinstall di tempatnya Dr. Lisa. Kita lagi proses untuk nemates dan lain-lainnya. Kemudian satu lagi di tempatnya Dr. Ayu di Hermina Bekasi, itu kemungkinan kita akan mechanical installation di bulan ini karena alat sudah datang. Oke, dan jangan lupa Dok, kami juga punya booth Dok. Jadi kalau misal nanti ada masih banyak pertanyaan ke kami, silahkan datang ke booth kami Dok. Booth kami ada di booth nomor 2. Kebetulan kami juga full tim ke sini, jadi kalau misal dokter berbondong-bondong ke kami siap untuk mencoba menjawab apa yang jadi pertanyaan dokter dan juga kekhawatiran dokter saat ini kami. Oke, demikian yang dapat saya sampaikan, Bapak dan Ibu dokter sekalian. Kurang lebihnya saya mohon maaf. Wabillahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Baik, berikan aplaus dulu untuk Mas Wahyu dari Unite Imaging. Jadi nanti kita diundang untuk ke booth-nya Unite Imaging ya. Pastinya akan banyak souvenir dan merchandise dari sana. Oke, es krim gratis. Oh ya, siap. Oke, baik. Hari ini saya merangkap selain menjadi MC, saya juga sebagai moderator dan juga sebagai presenter. Jadi untuk presentasi berikutnya saya sendiri. I'm sorry to Professor Stockel and Professor Natlenzo. From now on I will speak in bahasa so they can understand better. Okay, so jadi bahasa Inggris lagi. Jadi sesi berikutnya tentang saya akan coba sharing ke teman-teman bagaimana cara membuat report PET CT yang sesuai dengan standar ya. Jadi sebenarnya ini dikembalikan ke gaya kita masing-masing sebagai dokter spesialis kedokteran nuklir dalam membuat report. Saya yakin teman-teman di sini sudah berpengalaman dan sudah menjadi pekerjaan sehari-hari kita adalah membuat report ya untuk diagnostik. Tapi ya kita juga perlu menseragamkan mungkin ya, atau bukan menseragamkan, nggak mungkin kita bikin semua report di PET CT di Indonesia itu sama. Tapi paling nggak standar, sesuai dengan standar gitu. Artinya semua informasi yang dibutuhkan dalam report PET CT itu kita bisa masukkan ke dalam report kita. Jangan sampai justru malah informasi yang penting dan dibutuhkan oleh teman-teman sejawat klinisi malah kita nggak masukkan. Ya, mudah-mudahan saya bukannya bermaksud untuk mengajari atau bermaksud untuk meminta untuk format reportnya teman-teman itu sama dengan saya atau teman-teman yang dari Siloam, tapi paling nggak kita bisa sharing seperti apa sih format report PET CT yang sesuai standar dan baik itu ya. Ini, saya sambil duduk aja kali ya. Nextnya gimana? Ini yang mau saya bicarakan. Saya akan menyampaikan elemen-elemen apa aja yang perlu dimasukkan ke dalam report yang lengkap. Terus gaya kita membuat report, kemudian deskripsi ya yang kita bisa masukkan ke dalam report kita dan poin-poin penting apa yang perlu kita masukkan ke dalam report kita. Ya sebenarnya untuk membuat report sendiri itu sudah ada guideline-nya sendiri ya, baik itu dari ISNM maupun dari SNMMI. Nanti tinggal dibuka sendiri guideline-nya seperti apa, tapi secara singkat saya akan sampaikan di presentasi kali ini. Yang pertama adalah mengenai identitas pasien dan informasi dari pemeriksaan yang akan kita buat report. Ya, biasanya kalau teman-teman yang pernah stase di MRCC atau pernah lihat report kita, itu yang paling atas itu adalah kolom mengenai identitas pasien, mulai dari nama, jenis kelamin, nomor medical record, tanggal pemeriksaan, tanggal lahir, ya terus jenis pemeriksaannya apa, apakah PET CT dengan FDG atau PET CT dengan PSMA atau radiofarmaka yang lain tuh harus ditulis di awal atau kolom pertama dari report kita. Ya, dan klinis histori riwayat klinis dari pasien itu juga kita masukkan di awal-awal dari format report kita, siapa dokter pengirimnya, ya karena ini penting supaya kita tidak ketukar, ya. Identitas pasien ini penting sekali. Jadi pernah saya udah capek-capek bikin report selesai, ternyata salah pasien. Ya, tanggal lahirnya namanya mirip sama tapi tanggal lahirnya beda atau nomor medical recordnya beda. Jadi benar-benar perhatikan dari awal sekali apakah identitas pasien yang kita baca atau kita buat reportnya itu sama dengan yang kita buat reportnya, ya jangan sampai kita kerja 2 kali nanti. Yang kedua adalah kita masukkan juga ke dalam report kita bagaimana persiapan dan kualitas dari gambar yang kita baca. Ya kita perlu masukkan berapa gula darahnya, kalau perlu berapa lama dia puasa gitu ya, dan bagaimana kualitasnya. Ya, secara visual kualitatif kita bisa menilai gambar yang kita baca itu atau yang kita lihat itu apakah memenuhi standar atau tidak. Ya, kita kan sudah banyak belajar ya mengenai kualitas gambar PET yang baik itu seperti apa. Kalau dia backgroundnya tinggi, terus uptake FDG atau uptake radioaktivitasnya di otot tinggi itu termasuk tidak layak baca. Banyak hal-hal yang mempengaruhi gambar dengan kualitas yang tidak layak untuk dibaca, seperti penyuntikan yang ekstravasasi atau dosis kurang atau waktu akuisisi yang melebihi standar. Ya, jadi banyak faktor yang bisa mempengaruhi gambar. Nah, itu harus dicatat. Kita pernah di MRCC itu kita shutdown pelayanan PET CT sampai 3 bulan karena kita menilai kualitas gambar yang dihasilkan itu sudah tidak baik. Ya, karena itu akan mempengaruhi tingkat akurasi dari pemeriksaan PET CT. Kalau memang kualitas gambar nggak baik, kita jangan pernah mencoba untuk berani-berani membuat reportnya, ya. Karena kalau sampai kita salah diagnosis atau misdiagnosis, itu nanti akan menentukan arah treatment selanjutnya dari pasien kita, ya, dan kita malah membahayakan pasien. Itu nggak bisa menyalahi prinsip dari patient safety. Ya, jadi kalau begitu kita lihat kualitas gambarnya itu nggak bagus, lebih baik di reschedule atau dibatalkan. Ya. Kemudian parameter pencitraan juga kita masukkan dan metode rekonstruksinya juga kita masukkan kalau perlu ya. Dan kadang-kadang perlu juga dimasukkan jenis kameranya, apakah dia menggunakan United Imaging, Siemens atau GE, apakah pakai kontras atau non kontras gitu ya. Itu dimasukkan semua di teknik pencitraan. Ya, dan kalau saya pribadi, saya masukkan di mana injection site-nya. Ya, karena pada pasien-pasien breast cancer, injection site itu bisa mempengaruhi karena kita kadang-kadang bisa lihat normal atau fisiologis FDG uptake di aksila yang bisa membuat kita jadi misinterpretasi false positif sebagai lymph node. Nah, kalau kita masukkan injection site dan ada uptake FDG di aksila yang dengan sisi yang sama pada injection site, kita bisa tulis bahwa itu bisa karena retensi dari radioaktif di vaskuler. Ya, jadi kalau saya tulis injection site-nya. Terus pengukuran SUV itu apa yang kita pakai? SUV itu kan ada macam-macam ya. ada SUV max, ada SUV min, ada SUV average, ada SUL. Nah itu sebaiknya dicantumkan juga tuh di deskripsi dari teknik pencitraan. Oke. Berikutnya adalah jika kita membandingkan, biasanya pasien yang untuk dinilai respon terapi atau untuk follow up, itu kita membandingkan dengan pemeriksaan sebelumnya. Itu kita tulis di dalam deskripsi bahwa pemeriksaan ini dibandingkan dengan hasil sebelumnya. Dan kadang-kadang jika memang diperlukan, kita tidak harus membandingkan dengan sama-sama harus PET CT juga. Ada pemeriksaan sebelumnya yang memang kita nilai perlu untuk dibandingkan seperti CT scan dengan kontras atau MRI, itu kita bisa bandingkan juga dengan pemeriksaan tersebut, dan kita bisa tulis di report bahwa jika dibandingkan dengan pemeriksaan CT kontras tanggal berapa, ukurannya bagaimana. Walaupun pemeriksaan sebelumnya itu bukan PET CT ya, itu bisa kita tulis di situ. Karena kadang-kadang dari dokter pengirim itu mereka minta dibandingkan, ya dibandingkannya nggak harus dengan PET CT tapi juga dengan modalitas pencitraan yang lain. Itu kita harus tulis. Nah, gimana dalam membuat deskripsi? Ini yang kembali ke gaya kita masing-masing ya. Kalau kita perhatikan mungkin ada salah satu guru kita yang punya gaya menulis report yang khas gitu ya, yang selalu pesannya, kita kan nuclear medicine, jadi kedokteran nuklirnya dulu dong yang diutamakan. Kalau diterapkan ke sejawat yang lain, itu kelihatannya agak kurang pas, karena beberapa dokter yang kita paksakan dengan konsep atau prinsip guru kita tersebut, itu mereka malah justru nggak ngerti dengan kalimatnya, karena mereka tuh nggak begitu penting mau nuclear medicine dulu atau mau CT scan-nya dulu yang ditonjolkan, diutamakan tuh buat mereka nggak penting. Yang penting adalah kalimatnya mudah dimengerti, ya struktur kalimatnya itu harus sesuai dengan ejaan yang di EYD itu ya. Kalau almarhum Prof Johan itu kan cerewet banget tuh kalau kita bikin report kalimatnya nggak sesuai dengan EYD itu. Pengalaman saya waktu residen dulu sampai bolak-balik 7 kali bikin report thyroid scan hanya karena kalimat yang nggak sesuai dengan bahasa Indonesia yang baik. Jadi sebaiknya kita deskripsikan temuan yang kita lihat di gambar pasien itu sesuai dengan struktur kalimat yang baik dan subjek, objek, lokasi dan keterangan itu harus jelas. Anatomi itu bisa kita sebut dulu, misalkan ya ada nodul, kita sebut dulu subjeknya adalah nodul. Nodulnya bagaimana dari sisi PET CT-nya, apakah menangkap FDG atau tidak menangkap FDG. Terus lokasinya di mana? Ya, apakah nodul yang menangkap FDG itu ada di payudara atau di tiroid atau di mana gitu. Nah, terus keterangan tambahannya apa? Misalkan dia melekat pada kutis atau melekat pada pektoral. Jadi kalimatnya itu, kalau ada beberapa teman kita yang, saya nggak mau nyebut nama, tapi itu FDG uptake-nya dulu yang disebut. Penangkapan FDG pada multiple lymphadenopathy. Nah itu ada beberapa sejawat yang nanya, kalau jadi yang dinilai itu FDG uptake-nya apa lymph node-nya, gitu kan? Kalau lymph node-nya nggak menangkap, tapi dia ganas, bagaimana gitu? Nah, yang penting kita bisa menjelaskan aja. Setiap kali kita ditanya oleh sejawat, apa maksud dari kalimat yang kita tulis, yang penting kita bisa menjelaskan. Tapi kalau saya lebih memilih kalimat yang aman. Jadi jangan ambigu gitu, jangan membuat kalimat kita itu menjadi pertanyaan teman-teman sejawat. Itu akan merepotkan kita. Tengah malam kita ditelepon cuma nanya, ini kalimatnya maksudnya apa ya? Nah, repot kita. Jadi lebih baik cari aman, pilih kata-kata atau kalimat yang umum, yang dokter lain bisa mengerti. Ya, dan jangan lupa harus dikorelasikan dengan pertanyaan dokter yang ngirim. Jangan gak nyambung, misalkan dia nanyanya staging, ya kita harus tulis di report sistem staging itu kan ANM ya. Harus masuk tuh T-nya gimana, N-nya gimana, M-nya gimana. Jangan malah kita nggak masukin apakah ada metastasis lymph node atau nggak ada gitu ya. Walaupun nggak ada metastasis lymph node, tetap harus ditulis di report. Ya, supaya mereka bisa tahu apa yang mereka tanya. Oke. Terus kesimpulan. Nah, ini kesimpulan penting. Biasanya di deskripsi kita akan menulis panjang lebar gitu ya. Apa temuan kita di sana. Tapi jangan nanti di kesimpulan atau di impression itu kita copy paste dari deskripsi. Sama aja panjang juga gitu. Jadi apa bedanya tuh antara deskripsi sama kesimpulan? Ya, ini saya suka lihat di beberapa report MRI atau CT scan. Jadi sama aja antara deskripsi, hampir sama lah. Nah, kita sebaiknya membuat kalimat di kesimpulan itu tidak lebih dari 5 baris. Ya, ada yang bilang kesimpulan yang baik itu adalah singkat, jelas, padat. Ya, kalau terlalu panjang bukan kesimpulan namanya. Dan harus menjawab dari pertanyaan atau masalah. Ya, dan memberikan dampak bagi penata laksanaan pasien tersebut. Karena beberapa sejawat itu dia nggak baca deskripsi tuh, dia baca kesimpulannya. Ya. Nah, di kesimpulan itu kita harus masukkan, dan jangan cuman kita copy paste temuan tapi kita tidak menganalisa atau menyimpulkan. Contoh, multiple limfadenopati di hipermetabolik atau yang menangkap FDG tinggi di aksila, titik. Tapi nggak ada kesimpulan atau hasil analisisnya apa. Kita harus masukin hasil analisisnya. Itu apa? Misalkan sugestif metastasis atau sugestif proses reaktif. Jadi kita menjawab gitu. Ya, kita harus beda sama sejawat yang lain. Ya, yang radiologi diagnostik tuh kadang-kadang mereka nggak menjawab. Mereka cuman tulis ulang apa yang mereka tulis di deskripsi. Oke. Nah, ini gaya dari membuat report itu macam-macam ya. Ada di antara kita yang buat report itu berdasarkan dari temuan yang penting. Ya. Jadi mana dulu yang kira-kira bermakna dari hasil PET scan-nya ini. Misalkan dia ada nodul hipermetabolik di payudara. Dia itu dulu yang di kalimat pertamanya. Jadi bukan dari kepala sampai ujung kaki gitu. Ya. Kalau di tempat saya kan dibagi region tuh, kepala leher, torak, abdomen, pelvis gitu. Nah, itu juga bisa, itu salah satu dari gaya untuk membuat report. Tapi ada yang pertama itu yang utamanya dulu, temuan utamanya dulu. Ini kayak mungkin nggak kelihatan ya. Tapi ini dari sejawat kita di negara tetangga, ya dia selalu yang utamanya dulu yang ditulis. Bahkan ada yang sama dia dibikin untuk yang perbandingan dibikin bagan. Ya, dia bandingin yang sebelumnya di sebelah kiri, yang sekarang di sebelah kanan. Terus keterangan itu kesimpulan dia apa? Apakah ada perbaikan, perburukan atau stabil? Ya, ini memudahkan nih. Ini saya mau buat seperti ini, cuman masih ragu-ragu apakah nanti bisa diterima oleh sejawat apa enggak. Tapi kalau saya lihat report gaya report seperti ini nih mungkin bisa diterapkan. Nah, ini mungkin udah sering ya ngelihat kalau yang stase di MRCC. Kalau di kita ini berdasarkan regio anatomi kepala leher, toraks, abdomen, sama muskuloskeletal. Atau hibrid di combine. Jadi tetap berdasarkan regio, tapi yang temuan utamanya ditulis duluan. Ya. Contohnya yang di abdomen pelvis ini yang utama yang kira-kira akan berdampak signifikan pada penata laksanaan pasien kita masukkan di kalimat pertama. Ya, di abdomen pelvis ini ada non-FDG evid hypodensilation di lobus kanan hepar. Ini kita tulis dulu. Oke. Yang ketiga, kita sebaiknya menggunakan istilah-istilah yang standar. Ya, jadi untuk lokasi kayak di paru itu kan ada yang pakai istilah segmen, ada yang pakai istilah lobus. Nah, kita mesti konsisten tuh mau pakai yang mana. Mau pakai segmen apa lobus. Kayak radiologi mereka kayak lymph node di mediastinum mereka pakai angka, ya kan. Lymph node 4, regio 4, kayak di leher juga sama. Nah, kalau kita kelihatannya karena guru-guru kita mengajari pakai istilah ya, jadi untuk lymph node kita pakainya paratracheal, terus paraesophagus atau orthopulmonary window gitu, atau jugular superior. Ya itu sih kita udah nggak ada masalah. Tapi harus konsisten, jangan berubah-berubah. Hari ini kita pakai istilah, terus besok pakai angka nomor. Jadinya malah image-nya nggak bagus. Ini dokter SPK-nya kok nggak konsisten ya. Kadang pakai angka, kadang pakai kata-kata gitu. Terus kita juga harus jelas mendeskripsikan ukuran, terus infiltrasi ya sudah meluas sampai mana. Walaupun sebenarnya kita bukan anatomical imaging, tapi kita punya CT scan yang meskipun itu bukan diagnostik, tapi kita bisa pakai untuk mendeskripsikan secara anatomi. Ya, apakah ada keterlibatan infiltrasi ke kutis atau ke pektoral ya, atau ke yang mana, itu kita bisa deskripsikan di report kita juga. Terus intensitas penangkapan radioaktifnya juga kita mesti sebutkan, apakah menangkap FDG ringan, FDG sedang, atau menangkap FDG tinggi. Ya, karena itu penilaian secara visual kualitatif, walaupun secara kuantitatifnya kita masukkan nilai SUV-nya juga. Yang perlu kita standarisasikan atau satukan persepsi adalah mengenai istilah FDG uptake. Ya, FDG uptake di sini mencerminkan tingkat dari aktivitas metabolik. Ya, dan SUV itu juga kadang-kadang ada sejawat yang minta SUV-nya dimasukin. Walaupun sebenarnya kita tahu ya, SUV itu kan nggak signifikan atau nggak bisa dipakai untuk membedakan ganas atau jinak. Jadi walaupun sebenarnya kita berpikir ngapain masukin nilai SUV, nggak ada maknanya juga. Tapi sejawat itu tetap minta SUV, ya, karena mereka akan yaitu menentukan apakah perlu biopsi atau enggak. Kalau SUV-nya rendah, kadang-kadang mereka akan tidak melakukan tindakan yang agresif atau invasif. Tapi kalau SUV tinggi baru mereka akan melakukan tindakan agresif. Jadi walaupun menurut kita SUV itu enggak bermakna untuk membedakan ganas atau jinak, dari sejawat itu mereka minta nilai SUV. Jadi usahakan untuk masukkan nilai SUV. Ya. Dan tetap harus sesuai dengan konteks klinis yang ditanyakan oleh sejawat. Oke, terakhir. Jadi kita dalam membuat report harus sesuai dengan standar walaupun dengan gaya bahasa atau kalimat masing-masing. Baik, sampai di sini ada yang mau ditanyakan, silakan kita diskusi aja ya. Silakan Mas Bambang. Monggo.
Kami beberapa kali dari Sarjito memang ada sering mengirim pasien ke MRCC terutama dan Darmais. Namun pada saat kembali DPJP ada beberapa bukan sering sih dok, ada beberapa yang memang meminta reinterpretasi lagi dok. Di situ mungkin secara personal kami japri ke dokter yang menginterpretasi, tapi kami agak mempertanyakan, maksudnya reinterpretasi dari DPJP itu suka sebenarnya nggak ada yang kita rubah, tapi konsepnya ini masih agak ngambang gitu maksudnya. Apakah dari pengalaman dokter sendiri, ada nggak pengalaman dari MRCC sendiri, apakah ada konsep reinterpretasi itu? Karena kalau dari radiologi itu sudah ada tarif sendiri ternyata dok untuk reinterpretasi CT, MRI. Nah di kedokteran nuklir sendiri kami masih awam, terutama di sini, karena kan ya maaf ya dok, jadi kayak mempertanyakan hasil interpretasi dari sejawat sendiri gitu dok. Dan kami agak masih belum jelas ini konsepnya seperti apa. Mungkin dokter Rian yang sudah ini ada konsep pengalaman nggak seperti itu?
Baik, makasih Dokter Bambang. Ini kita diskusi aja ya. Nanti kalau jawaban saya kurang memuaskan, nanti mungkin Dokter Uti atau Dokter Ayu bisa menambahkan yang sama-sama udah pengalaman juga dalam membuat report PET-CT. Jadi ya memang betul yang dialami Dokter Bambang itu juga kita alamin juga tuh di MRCC, sering ditanya report dari sejawat teman yang SPKN yang lain. Ini maksudnya apa? Sebenarnya hanya bertanya, mungkin kalimatnya buat kita sebagai nuclear medicine kita mengerti gitu ya, tapi mungkin buat sejawat yang bukan nuclear medicine kalimatnya itu sulit dimengerti. Ini yang saya tadi sampaikan bahwa gaya waktu saya baru lulus dulu, gaya bahasa yang dari tempat saya belajar itu saya pakai di situ, justru malah saya banyak dipertanyakan. Nah, maksudnya apa ya? Maksudnya apa ya? Oh, akhirnya saya tanya, akhirnya saya jadi tahu mereka tuh maunya kayak apa sih? Sejawat kita di rumah sakit Jakarta, Bandung, Jogja, Semarang itu kan punya budaya bahasa masing-masing ya. Gak bisa disamaratakan tuh, ternyata walaupun sama-sama bahasa Indonesia tapi bahasanya itu gaya bahasanya itu beda-beda. Jadi waktu saya pakai gaya bahasa yang dari Bandung itu buat sejawat yang di Jakarta menurut mereka ya agak sulit dimengerti. Akhirnya saya rubah gaya bahasanya dengan gaya bahasa yang biasa dipakai di Jakarta gitu. Nah, tapi ya itu kembali ke ke budaya bahasa masing-masing. Akhirnya dengan kita bertanya maunya seperti apa sih kalimatnya? Ya, mungkin teman-teman juga bisa perhatiin di MRCC sendiri kita berempat SPKN full timer di sana, tapi gaya bahasanya kan beda-beda. Ya, dan kita ini kan istilahnya ya kayak jasa, kita ini menjual jasa kan. Setiap kali kita memberikan jasa kita ke setiap customer yang atau klien yang kita layani, itu kan customer atau klien punya keinginan yang beda-beda. Ya, misalkan pada dokter A ini maunya jawaban yang singkat, jelas, padat, langsung to the point. Tapi ada dokter lain yang mau, lu ini dong bikin yang istilahnya yang lengkap dong, yang yang nggak penting juga masukin aja. Pasien kan udah bayar mahal, masa cuma segini doang gitu kan. Ada yang kayak gitu. Jadi kita harus menyesuaikan dengan customer atau klien kita. Mereka bahasanya mau kayak apa. Nah, pas kebetulan yang mungkin dokter dari sejawatnya Dokter Bambang dari Jogja, ya dia punya keinginan yang lain, yang saya biasa ngirim ke radiologi kalimatnya kayak begini, kok dapat yang dari nuklir kalimatnya kayak gini. Nah, kita yang harus menyesuaikan sama mereka, jangan mereka yang harus menyesuaikan sama kita. Ya, mungkin harus diingat juga kita ini jualan jasa ya gitu. Jadi ya harus sesuai dengan keinginan klien. Kira-kira seperti itu. Menjawab nggak Dokter Bambang? Kalau nggak menjawab mungkin Dokter Uti atau Dokter Ayu bisa nambahin.
Bagaimana dengan ininya dok? Maksudnya itu menjawab dok. Terima kasih matur nuwun. Dari pihak yang membacanya sendiri dok, apakah ngapunten sekali? Apakah jadi enak atau enggak dok? Secara secara etik gitu, secara interpretasi itu jadi nggak sampai konsep meragukan, nggak kan ya dok ya seperti itu? Karena kami juga melihat ini, ini udah jelas Cuman mengalih bahasakan mungkin ya dok ya, jadi jatuhnya.
Itu kalau menurut saya ya, kita yang paling penting adalah melindungi sejawat kita sendiri dulu. Jangan langsung kita salah-salahin juga nih SPKN-nya. Nah, itu berbahaya, maksud saya itu nggak etis lah ya. Kalau memang ada kita lihat salah nih, kita bisa menggunakan bahasa yang lebih halus. Ya, oh ini mungkin maksudnya teman saya ini begini, nggak salah. Tapi mungkin ada yang kurang dan itu kita bisa tambahkan. Ya, dan biasanya kalau cukup selesai dengan telepon atau WhatsApp, ya udah selesai gitu kan. Yang penting dokternya itu ngerti maksudnya apa, tapi jangan pernah kita mengkambing hitamkan sejawat kita sendiri. Kita justru harus melindungi, di situ kan gunanya keluarga. Kita kan satu keluarga. Ya, jangan dijelek-jelekin lah, itu black campaign, nggak bagus. Ya, kita lindungi, di keluar kita melindungi, tapi ke dalam kita hubungin tuh, kita kontak sejawat kita itu, lu bikin report begini nih, yang ngirim dokter perujuknya jadi nggak ngerti, nggak paham gitu, maksudnya begini gitu kan. Kita klarifikasi lagi, kita tanya gitu. Tapi kalau udah selesai, cukup dengan dijelaskan dokter perujuknya ngerti, paham, ya udah selesai. Tapi kalau misalkan sampai tolong dong dibuat report lagi, di reinterpretasi, terus diketik, ditulis, ya itu sah-sah aja dan memang harus kita cas, ya kan? Karena ada beberapa dokter yang ngirim tuh minta walaupun isinya sama ya, kita pastikan juga ke dokter yang ngirim, ini saya analisa ulang tapi nggak ada yang berbeda loh dari yang lama, tapi mungkin dengan gaya bahasa yang dia pengen dia yang lebih ngerti lagi. Itu Dokter Bambang.
Jadi intinya memang ya harus kita sepakati ya dok ya, walaupun memang ada konsep reinterpretasi ini, jadi yang antara yang menginterpretasi ulang dan yang interpretasi awal tidak ada konflik etik di situ mungkin dok ya? Ya di situ dok.
Enggak, dan kita juga yang dikritik jangan baper juga. Saya Dokter Ivana, Dokter Feby, Dokter Hafsari itu sering biasa. Kan kita ada MDT tuh. MDT itu kan bahas pasien itu selalu ada PET CT-nya, dan PET CT-nya itu kadang-kadang ada yang salah atau ada yang apa. Pertama kita lindungin dulu yang salah itu. Oh, ini mungkin typo aja dok gitu kan. Maksudnya ini kanan kiri gitu. Ya udah, kalau udah selesai gitu. Tapi kita tetap kasih tahu teman kita, lu kemarin bikin ini nulis kanan kirinya kebalik gitu kan. Ini contoh aja. Oh iya sorry. Ya kayak gitu aja. Jadi kita saling mengingatkan, saling memberitahu gitu ya. Gitu. Jadi Dokter Bambang. Siap. Ya harus kompak kita sesama SPKN.
Siap, kompak selalu.
Ada lagi nggak?
Ada 3 lagi pertanyaan dok.
Oh iya, ntar sekali lagi dapat gelas.
Siap. Ditunggu.
Kenapa?
Ditunggu dok.
Dokter Bambang.
Untuk perbandingan dok, berapa lama antara PET CT dan PET CT kedua itu ada batasnya nggak dok? Maksudnya kalau misalnya pasien itu datang terus konyong-konyong membawa PET CT yang 3 tahun yang lalu, 2 tahun yang lalu. Nah ini gimana ya dok? Kalau misalnya ada batas waktunya.
Ada sejawat kita yang kalau udah lebih dari 2 tahun udah nggak bisa dibandingin, nggak usah dibandingin, monggo itu nggak salah. Tapi kalau misalkan dia udah 5 tahun yang lalu tapi gambarnya masih ada, saya bandingin juga. Karena mungkin aja progresifnya baru muncul setelah 5 tahun gitu. Tapi ya itu dikembalikan ke tadi gaya membuat report kita masing-masing. Kalau batasnya itu adalah 2 tahun. Kalau masih di bawah 2 tahun ya kita harus bandingkan. Kalau udah lewat 2 tahun boleh nggak dibandingkan.
Jadi secara literatur memang 2 tahun ya dok ya dok?
Iya, cuman saya nggak tahu literaturnya ada di mana, mesti dicari dulu.
Siap. Yang
di MRCC kita batasnya adalah 2 tahun.
2 tahun. Dok, maaf yang reinterpretasi tadi dok.
Oh, ini kasih gelas nih. Bercanda.
Dokter yang lain ada yang nanya enggak?
Enggak. Kalau enggak apa, borong aja.
Kita lanjut dulu, dok.
Apa Dokter Bambang, enggak apa-apa.
Ini agak sensitif mungkin dok. Charge-nya untuk reinterpretasi apakah seperti ya enggak apa-apa toh?
Ya, itu
ada charge-nya tuh maksudnya.
Ya,
gini,
ada
dok.
dong. Kayak kita nih
maksudnya tuh,
bukan spesialis murahan, kita harus ngecas.
Ya, real soalnya nih dok. Jadi memang di Sarjito sendiri memang ditanya dari konsep pelayanan pun ditanya ada berapa persen dari pelayanan itu kan kalau dari Kemenkes itu kan kita sudah dipatok di kedokteran nuklir itu jasa non operasi, tapi di luar tindakan operasi itu memang biasanya 15% dari tarif ini dok, 15% dari tarif yang dikeluarkan. Jadi itu untuk jasa dokternya kurang lebih. Nah kalau untuk tarif reinterpretasi ini kira-kira yang sudah ini sama dokter Rian dan teman-teman mungkin yang lain, senior-senior yang lain, itu ranknya itu berapa persen atau apa ada patokannya dok?
Ya kalau saya kan di swasta ya yang PET-nya udah berjalan, kalau di sini baru mau berjalan. Kalau yang di sini nanti tanya ke dokter Kido gimana kalau disuruh baca ulang, ngetik ulang itu capeknya hampir sama kayak kita bikin dari awal. Jadi tetap harus dicas. Tapi kalau saya di MRCC swasta kita casnya nggak sama, pasti beda. Kita ngecas 50% dari jasa medis kita yang biasa kalau kita bikin dari awal, 50%-nya. Saya nggak mau sebut nominal ya.
Iya, enggak.
Tapi
kan memang
setengahnya.
Beda, betul.
Setengahnya. Nah tapi kalau yang pemerintah BPJS saya nggak ngerti, nanti teman-teman lah yang lebih tahu. Tapi kalau saya usul mungkin setara dengan 1 kali konsul.
Yang 50% itu.
Kalau saya di MRCC 50% dari jasa medis yang normal.
Ya.
Artinya normal tuh mulai dari nol.
Mulai dari awal.
Ya. Dokter Uti, Dokter Ayu mungkin mau menambahkan dok dari pengalaman.
Sesama Kemenkes.
Dari sisi, silakan dok. Kita diskusi aja ya. Uti silakan. Ya.
Yang reinterpretasi sampai ke
ngecasnya gimana?
Casnya dok.
Dari Darmais gimana?
Karena kan ini mayoritas dari Kemenkes dan
ya sama sih prinsipnya itu nggak mungkin dicas sama dengan awal PET gitu. Jadi kita memang punya persentase itu juga diterapkan di pembacaan ulang imaging lain. Jadi memang tergantung kebijakan rumah sakit mau berapa persennya dari.
Ada dasarnya. Biasanya suka membandingkan. Ini di mana?
Kemarin berapa dokter Ayu yang kita baru ini kan baru ajukan
untuk
persentase
tarif reinterpretasi.
Persentasenya.
Persentase dari tarif dan itu tarifnya itu flat gitu, misalnya tarif bone scan gitu sama tarif PET scan itu bisa aja sama, misalnya jasanya 10% atau 5%. Nah nanti kalau ada billing re-expertise gitu, kita ajukan tarifnya sebut misalnya 1 juta, itu kita tetap akan dapat 10% atau 15%, enggak terus 1 jutanya nyampe ke kita. Jadi kalau di Darmais itu agak anomali, nggak bisa dijadikan patokan. Kayaknya itu harus kembali ke masing-masing dan kayaknya udah untuk tarif itu juga sudah disesuaikan sama perhimpunan ya, berapa persennya.
Udah disesuaikan dari perhimpunan?
Ya, dari perhimpunan kan udah ada rekomendasi kalau nggak salah.
Iya. Nggak
Reinterpretasi.
ada reinterpretasi itu kayaknya. Iya, maksudnya kan ada biar ada dasar. Nice.
Karena itu beda-beda. Kalau di ID yang dulu, dari dulu tuh ada apa namanya standar tarif dari ID. Kalau standar tarif dari ID itu untuk komponen yang banyak manpowernya, misalnya baca ulang atau kalau radiologi ultrasound itu kan banyak komponen manpowernya daripada BMHP atau memang bukan pelayanan yang berbiaya tinggi, tentunya bagi hasil jasanya juga lebih besar dari situ. Tapi itu kembali lagi karena juknis yang dikeluarkan dari Kementerian Kesehatan itu flat banget, isinya hanya 10%, 15%, 20%. Harus negosiasi lagi ke rumah sakit masing-masing dan saya rasa sih kalaupun di negeri tetap masih bisa dinego, asalkan kayaknya kuncinya kalau penyelenggaraan layanan kedokteran nuklirnya tidak bercampur dengan layanan yang lain sepertinya bisa diatur sendiri.
Mungkin dari perhimpunan nanti kita tambahkan ya. Nanti kita
Poin-poin.
diskusikan pada saat ini aja.
Ya,
Biar
Dok, aku
ditambahkan.
sedikit.
Oke,
Siap,
baik.
Dok.
Makasih Dokter Bambang masukannya.
Dok Rian, aku sedikit dari Sutomo. Ini kan kalau dari Sutomo kan sering dari Pineng ya, baca-baca ulang dari Pineng.
Lebih ini lagi.
Jadi selama ini kalau di Sutomo itu kami menyiasatinya dengan buat tarif konsultasi.
Ya, jasa konsul ya.
Ya jasa konsul jadi 500.000, gitu aja langsung sebutin. Jadi karena susah memang kalau misalnya kita masukkan di dalam tarif itu tuh memang agak susah, jadi lebih baik kami masukkan di dalam tarif konsultasi. Tapi biasanya seperti Dokter Ria bilang, biasanya kalau misalnya ada pemeriksaan itu kita cuman ya by telepon aja dulu ya dokter Ria, by telepon gitu. Kalau mereka bilang enggak bisa, kami harus tertulis, ya wes harus tertulis tapi konsultasi dengan ada pembiayaannya sendiri. Seperti gitu sih. Oke, makasih.
Baik, makasih. Kita cukupkan dulu ya, karena kita lanjut ke next speaker. So we move to the next lecture. Is from Professor Natlenzo. We already know him very well. He already many times come to Indonesia and give lectures. I don't need to introduce you again. So Professor Natlenzo will talk about how to use persist and resist. This is a very important topic, so please pay attention to his lecture too. Please.
It's still Salamat Pagi, isn't it? Yeah, still Pagi. So this is quite useful because of what Dr. Rian talked about with reporting. Have anyone here used resist or persist? Yes, very good. So these are my disclosures. So my talk, which I will hopefully get through in about 20 to 30 minutes to get us back on time, we'll go through these different areas. I'm just going to talk a bit about response assessment and what the principles are of resist, what the principles are of persist. I'll compare the two. It's a fairly easy concept. So the concepts are easy, doing it is not as easy. I'll give some examples. I'll talk about some of the limitations and then some tips and a summary. So introduction. So why do we need response criteria? So Dr. Rian talked about a standardized reporting structure, which is very important. But we want to know, and what we use a lot of PET for, particularly FDG PET, but no other forms of PET, including PSMA PET, is have our treatments work? Has the oncologist given a treatment that has improved the situation, or is the disease progressing, or is the disease stable? So the whole idea about these resist and persist is to try and standardize tumor response. Give some sort of objective measure rather than just looking at saying, yeah, it looks a little bit better, or it looks a bit worse. It also assesses the change in tumor burden, and it may provide some assessment of total tumor burden. You saw the talk from United Imaging. They can now give you, with some of these new AI techniques, total tumor volume, total tumor burden. So that's quite useful. There are clinical predictors of survival based on tumor burden. And the information we gather helps support clinical decision making. So the oncologist wants to know, do I continue with the same therapy? Do I change the therapy? Is the therapy working everywhere? Is there some disease where it's not working? And of course, a lot of this is developed because of regulatory compliance. So any research studies we do, they all want resist, and more of them now are looking at persist. So how do I use this information? I don't do formal resist on every case, but the concepts we use when we're looking at, is the disease progressing or not? Where do I use the formal resist and persist? In all my trials. So every drug trial we do, we have to do resist, we have to do persist in some of them. So the concepts are really important. So RECIST stands for Response Evaluation Criteria in Solid Tumors. So this is for solid tumors. Its current version is version 1.1, which I think came out in 2015 or 20, I can't remember. The original version is quite old. It is a size-based criteria and using CT or MRI. You don't have to take these images. These should be made available, all these slides, so you should get a copy of all these slides. So when we're doing RECIST for trials, we look at 5 target lesions, maximum of 2 per organ. So if there are multiple lesions in the body, I might take 2 from the lungs, 2 from the liver, and maybe a lymph node or something. So 5 lesions, and we're going to follow those 5 lesions across time points. And that's important. So when you're choosing the lesion, I will talk a little bit about it. You really want to choose lesions that are very clear to you. Then we measure the sum of the diameters and we compare the measurements over time. And I'll give you an example of that. And then we categorize. If everything disappears on imaging, it's a complete response. If it decreases by a certain amount in size, it's a partial response. It doesn't change very much, stable disease. And of course, if it's increasing significantly, it's progressive disease. So what do I mean by significant? So it is based on the sum of the diameters. So we baseline measure, we measure over time, and then we choose is it CR, PR, PD, or SD. For a partial response, you need to see greater to or equal to 30% decrease in the sum of the diameters. For progressive disease, I need to see a 20% increase. And stable disease is in between, and of course complete response is where everything goes away. So just visually, we have this one lesion which is 48 millimeters in its long axis. Now on a repeat study at a different point in time, it's 30 millimeters. So it's decreased 18 millimeters. 18 divided by 48 is a 37.5% decrease. So it's more than 30% decrease. So that is a partial response. Things can get bigger and smaller, and it doesn't mean you're responding by RECIST. So a tumor can go from 10 centimeters to 8 centimeters, and it is stable disease. That's only a 20% decrease. Tumor can go from 10 centimeters to 12 centimeters, and that is stable disease on RECIST, because it still hasn't gone more than 30% more. So for us on RECIST to say there's been a true partial response, that 10 centimeter lesion has to drop to 6 centimeters. Or if I want to say that there's been true progression, it's got to go from 10 centimeters to 14 centimeters. So that's very, very critical. Now, sometimes we don't use this to the same degree clinically. But on RECIST, this is the standard. Now, the tumor has to be measurable. It's got to be able to be measured at least in a dimension. So, and usually most lesions, it's long axis for, let's say, a pulmonary lesion, short axis for a lymph node. It's got to be at least 10 millimeters in size when you're going to measure it as part of RECIST. So if you have a lesion of 8 millimeters, and that's not one that we would routinely measure as part of RECIST. So as part of the pure RECIST criteria, it's got to be 10 millimeters in size. And you've got to look at what your CT scan slices are. So as part of pure RECIST, your slice thickness can be no greater than 5 millimeters. Now most CTs now are using, usually most of us reconstruct in 1 millimeter and 3 millimeters. But if it's more than 5 millimeters, then in the purest sense of the word, that's not the type of scan that you should be doing RECIST on. And then you should use a 10 millimeter caliper, that which is one of the tools that are on every workstation. So a lump, mass, a lesion, you choose the long axis, lymph node, the short axis, minimum 10 millimeters is abnormal. Just remember though, lymph nodes, a 10 millimeter lymph node is a normal lymph node on size criteria. So for lymph nodes, you can only have an abnormal lymph node if it's greater than 15 millimeters. So what do we call non-measurable lesions? So any lesion less than 10 millimeters, so an 8 millimeter lung nodule, 8 millimeter liver metastasis is non-measurable. It doesn't reach that 10 millimeter size. A 12 millimeter lymph node is non-measurable. You've got to hit that 15 millimeter size. And there are some disease which is truly non-measurable, like leptomeningeal disease, ascites, malignant pleural pericardial effusion. We can't really measure that using RECIST. You must use the same technique. If you use CT, you compare it to CT going forward. You don't compare CT to MRI. You don't compare CT to ultrasound. You use CT, you use CT. You use MR, you follow it with MRI. And then there are what we call non-target lesions. So you may have lots of pathology, but for RECIST we only choose 5. Then everything else we dump into non-target. Why do we do that? Because it's important to know what happens to the non-target lesions, but we don't want to spend the rest of our lives measuring 20 or 30 lesions. We haven't got the time, and it also isn't really necessary. And this is what a RECIST worksheet looks like. So you have the 5 lesions, the target lesions that you measure, and then you can put all the non-target lesions. With the target lesions, you'll see cycle 1, cycle 2, cycle 3, cycle 4, and you're looking at a change in size. For the non-target lesions, we just basically say, is it present or absent? So we're trying to capture as much as we can about the disease. So that's RECIST. Any questions on RECIST? We will go through some examples. It might make it a bit easier. So PERSIST is what is similar to the RECIST in that we're looking at response, but now we're using PET, and this is designed for FDG PET. And we use the SUV peak. It is not anatomical. It's functional or metabolic. So anatomical is RECIST, metabolic is PERSIST. We focus on the most metabolically active lesion. And then we look what happens over time. Is there a complete metabolic response? Is there a partial metabolic response? Is there stable metabolic disease or progressive metabolic disease? Very similar to the RECIST criteria. So you have a baseline FDG. Now it's important you have standardized uptake protocols. So in the very pure use of PERSIST, you make sure firstly that your scanner is qualified. So you make sure that you've had a NEMA phantom looking at your scanner, making sure that what you see, what you SUV you reckon you measure, you have measured. So that's the first thing. The second thing is you want to make sure that patients haven't got hyperglycemia, because that can affect, because if they're fluctuating sugar levels, that may affect your SUV. The third thing, which is one that we don't do very often, is if I do an SUV at someone after 30-minute uptake, or I do an SUV after a 90-minute uptake, they are not identical. So the changes that you see may be purely based on uptake. So when we do the repeat scans, we try and keep them as close to possible as the baseline. If I did my baseline at 60 minutes, I try and do my follow-up 60 minutes plus or minus 10 minutes or so. Very hard to do it the same, but a lot of people don't think about that. So what does PERSIST look at? Complete metabolic response, the activity's all gone away or virtually all gone away. Partial metabolic response, more than 30% decline in SUV peak. Partial metabolic, progressive metabolic disease, more than 30% increase, or if you see new lesions. If you see new lesions, then you have progressive metabolic disease, and stable metabolic disease is when there are minor changes. So just visually, this is a phantom, this is a lesion with an SUV peak of 12. A treatment, repeat it, the SUV is dropped to 7. it's dropped by 5. 5 divided by 12 is 42%. So that is a partial metabolic response on SUV criteria. So if we compare the two, RECIST, it's anatomical, it's size related. It's widely used, it's simple, it's very limited in early response. Anatomical changes take time. That's the beauty of a functional metabolic imaging. I remember the early Gleevec studies in GIST tumors. You could tell within 24 hours if your Gleevec was working using FDG PET. Do an FDG PET scan, give someone Gleevec, do a PET scan the day after, and you knew if your Gleevec was working. Because we see changes in metabolism that will take a long time to correlate to anatomy. It's going to take a long time for a tumor to shrink. So that's one of the benefits of PERSIST. It does require, as I mentioned, PET standardization, and that's something we're not very good at. There was a study done in Australia before, a study looking at gallium PSMA PET across the country, and the cameras, there were 30% plus discrepancies. And these were good institutes. These were not bad institutes. These were university institutes. So we have to standardize. So as I mentioned, this is just a different way of showing anatomy versus metabolism. With RECIST, we look at 5 lesions, 2 organs. In PERSIST, we look at the hottest single lesion. You can go up to 5, and then we see what happens with time. Those are that's the response thresholds, as we've mentioned. These are some of the strengths and also some of the limitations. So I'll give you some examples. So this is an example of a patient with metastatic disease and then we're looking at RECIST here. So they found multiple liver lesions, 2 which they felt are useful to use. Now, why have they chosen those 2? Well, they're relatively well circumscribed. I try and not use anything near a liver edge or anywhere near, let's say, a major vessel, major bile duct. Try and keep away from that, because when you're following that over time, that may affect your imaging. Then, of course, you want to look at it it's also got peritoneal disease, those 2 large peritoneal masses, which we're going to use. So 2 in the liver and 2 in the peritoneum. We look at the long axis measurements, use our calipers to determine what the measurements are. And then here we go. We've got our target lesion, we've got the peritoneal lesions, you have the sum of the lesions. Then we make a mention. Were there any non-target liver lesions? Yes, there were multiple present. Were there any other non-target disease elsewhere? Yes, in the peritoneum. Make a mention of that, and that's what your response chart will look like. And then we see that in January, that was the baseline. The sum of the measurements was 169. So repeat scan in March, there was a reduction in the size in the liver lesions and in the peritoneal lesions. The non-target lesions were stable because they were still present, and peritoneal lesions were stable because they were still present. But the sum of the measurements have dropped. So 80 drop in total size, so partial response. 2 months later, it's increased. So from 10, it's gone to 18. From 20, it's gone to 48. So even though it is still smaller than the original, it has still increased compared to the first cycle. So you don't compare it to the baseline, you compare it to the first cycle. But there was partial response originally, now there is progression. But this is the way we use it. So of course, we don't do this with every single case because this would take us a lot of time. We do it with every single research case. But the concept is how you should approach when you're looking at your clinical cases. And it is useful. Most of us do measure 2, 3, 4 lesions, and it's useful to try and measure those over time. Use them as a baseline for the future. So this is an interesting case, and I'll go back to it towards the end. So this is a patient with lymphoma. Now we're going to use PERSIST. We have this nodal mass The highest was SUV peak was 5.3. After treatment, unfortunately, SUV peak is 6. Stable disease. Hasn't gone up more than 30%, so it is stable disease. So what are the limitations? For both resist and persist, pseudo-progression. Has everyone heard of pseudo-progression here? You know what pseudo-progression is? Pseudo-progression. We see a lot of it with immunotherapy. You can also get it with some other biologicals, but particularly immunotherapy. So we see it both on CT and on PET. What happens is therapy goes in, it excites, you'd say for a better word, the immune system. The immune system attacks the tumor, and you can get a massive inflammatory response. So a tumor may swell, so it'll look bigger on resist, may get very inflamed, so it'll look hotter on persist, but that's a good response. In the early days, and I was one of the people who used to report these, I'd say this is progressive disease. And the oncologist would say, well, let's give it another cycle because he's looking better. And over time, it would get better. I'll give you an example of that. So just be careful. If you see something getting bigger and hotter on immunotherapy, doesn't mean it's getting worse. Could mean it's actually doing its job. So the other problem with resist is non-measurable disease. There are things that we can't really measure all that easily on resist, and sometimes we can see them on a PET scan. What's the other problem with persist? As we know, uptake can be very variable in tumours. We have non-FDG avid tumours, and we actually use slightly different clinical reporting systems for other conditions. So for lymphoma, basically Dualville is our main criteria, and that has some prognostic implications. And of course, for PSMA, we use RECIP. Has everyone heard of RECIP? If you haven't, I'll give you a website to go to. Other pitfalls, technical factors. How you acquire, how you reconstruct is very important. There is some inter-reader variability. The way that I measure something can be slightly different to someone else, and that's why some of these AI programs may be of use. And also, why do we do this? We do this for our clinical colleagues. So really, it's important because of the multidisciplinary nature of the way we practice oncology. They need our information, we need their clinical input. So this is pseudoprogression. So this is a lesion in the lung, non-small cell lung cancer, treated with immunotherapy. The mass actually has got bigger in size and has got hotter. But if we monitor the SUV, it goes up and then it goes down. So in fact, this patient is having response to therapy even though we're seeing these changes. So you just need to be worried about that. That's where resist and persist can have issues. And often we get discrepancies. So this is a patient with a large breast mass extending into the axilla. Very hot on SUV, very large on CT. After treatment, you see a partial response because there's still a sizable mass. But in fact, you see a complete metabolic response on anatomic. So that's why it is actually very useful to look at both the CT and the metabolism. But likewise, this is a patient with a lymphoma, extensive disease, treated on CT. We see a partial metabolic response because the lymph nodes have got much smaller. But in fact, on PET, the SUV, yes, it's dropped, but it hasn't dropped significantly enough. So it is still stable disease on PET. That has a prognostic implication. So some reporting tips. Always define your baseline lesions very clearly. Try and use structured reporting templates, which is what Dr. Rian was talking about. Try and correlate what you see on anatomy with function, resist and persist. Comment on both of those and highlight limitations and uncertainty. For those, I'm sure everyone knows about the Durville criteria, but that's the way we basically look at response assessment for lymphoma. RECIP is the way we look at response assessment in prostate cancer. PROMISE is the reporting structure for PSMA PET. And of course, AI, things like MIMS, AI PROMISE, AIQ solutions, those are the ones that I've used. These are still not yet accepted. They're still in validation. Just to give you an example, so this on Durville criteria, the patient who we said had stable disease, this is Durville criteria 5. That is not good. If you have persistent active disease after, this will probably 3 cycles of therapy for lymphoma, that is a bad prognostic sign. So even though PERSIST says it's stable, clinically that's not great. This is one of the programs we use, AI PROMISE. This is actually an interesting patient. This is a patient with prostate cancer. You'll see down the bottom, it's a bit hard to see, but on the 10th of April, they had 11 lesions. SUV max was 36. The total volume was 68 mils. After 2 cycles of PSMA therapy, they've had quite a very good response. So this is all done automatically. And we've actually validated this. We've done it physically and looked at it to validate the program. But this, we need more validation of these AI programs that will make our life a lot easier. So in summary, RECIST is size, it's relatively simple, it's widely used, it's used in all the clinical trials. PERSIST, metabolism-based, sensitive, is PET specific. These are complementary tools in oncology imaging. Standardization is essential, and we use it for clinical decision making. And I've mentioned PSMA PET lymphoma is slightly different. AI hopefully will improve speed and reducibility. So, terima kasih. And just over time. Questions?
Thank you, Prof. Nat Lenso. I want to ask about the best timing for do the PET CT before and after therapy, which is as you mentioned before, there's pseudo progression, how to manage it, and then the maximum time to take the first PET and then second PET is the maximum time of 2 years, or and the best time for take the PET CT for monitoring therapy. And then the second one, if the first use like GE from PET from GE, and then we do PET from such as UI, can we do the PERSIST? Because I thought that there is variability among the modality we use. Have you experience for that? Thank you.
I'll answer the second one first because that is a lot easier to answer. You can use different scanners, but it's about getting standardization and getting the cameras validated. So in the perfect world, for research studies, we use different cameras all over different institutes. Some are Siemens, some are GE, some are United, some are even old Philips. As long as they've been qualified and validated, then you can compare. It gets harder in the clinical setting because most cameras haven't been validated so accurately. So when you get an SUV from one place and then you're trying to compare it to an SUV from your own, depends on what the uptake time was, depends on the scanner. So that can be difficult, and that is correct. So when I get a scan report, and it is hard to be very accurate in measuring. Now, of course, if the SUV went from 20 to 2, it's highly likely that is a true effect. But if it goes from 20 to 16, maybe there's not. It might not just be scanner variability. So it's just something to be aware of. But in our research studies, that's something we're very particular about. But so you can compare, but that's a very good question. It can be difficult. To answer your first question, when's the best time? So one would say as soon as possible to the treatment would be the best time to do your baseline, but that can depend because tumours change over time and sometimes quickly. So you want to get your baseline as close to possible when you're to your first cycle. Definitely probably within the first month if you can, before your first cycle of therapy. We do have structured timing for follow-up in certain cancers. So I think the lymphoma groups have worked really well, and they now know it's usually 3 cycles, then reassess. And they would usually sort of try and do it halfway between one cycle and another, so to give time for any inflammatory response or whatever. So, but in other cancers, we're not as well. We haven't worked it out as well, and there's a number of reasons for that. In many cases, reimbursement hasn't been allowed for follow-up PET, and so even in my country, a lot of the early PET scans are only allowed a staging PET scan for, let's say, lung cancer. So it's only relatively recently that we've been able to do follow-up PET scans. They seem to be following what we do in CT, which is it's the CT standard protocol for oncology seems to be 3 monthly. You do your therapies, then you do a 3-month CT. And it seems to be following up that way with PET CT. But the time of when it's actually best, I think will vary for different cancer types, and we haven't really worked that out very well. But 3 monthly PET seems to be fairly uniform, at least in my part of the world. There are times, however, when an oncologist may want done sooner. So if they're very worried about something, or they're trying a new treatment, they want to know as soon as possible, they may say, look, I'm going to give 1 or 2 cycles and I want to know. So, but it is variable. As I said, lymphoma, we're very definite. We know how it's after the 3rd cycle, that's quite, and then at the end of treatment. With other cancers, it seems to be 3 monthly, which seems to follow the CT protocol. But in many ways, we're guided by the oncologist. I don't know if Marcus, you have any other comments on that?
You're quite complete with respect to the SUV measurements and the standardization and harmonization of the cameras. We use the EARL accreditation within Europe, and if you apply for that and you send all the data to the center that in fact gives you the accreditation, you're on the safe side. But we have the same problem in the Netherlands and within Europe, that we have multi-center studies in which some cameras are not correctly as standardized as the others. So and then we have really big problems. But yeah, that's real life and daily practice.
Of that problem.
Well, nowadays, if we run a study like that, a multi-center study, they have to prove that they have the accreditation, and if not, they're not accepted as a center to participate in the study.
You cannot do the persis like response therapy.
If you do not have the accreditation, you cannot properly do the response criteria. You have to be, you have to have the accreditation, and then you know that what you measure is really correct. And if you do not have it, you never know what the variability will be over time. You have to realize that the accreditation, the EARL accreditation, is related, in fact, to FDG PET scanning, and it is not related to PSMA scanning or the dotatate or I mean, it's really difficult when you go to zirconium-labeled antibodies or whatever, and that makes it really difficult. So harmonization, standardization, before we start a study in Europe and we are going to use zirconium labeled antibodies, we have to standardize all the cameras and the protocols, etc., that you're all on the safe side.
Then how about the timing?
Yeah, it depends on the study protocol. I mean, you can do a PET scan after 1 week or 2 weeks, and if you see a good response, they say you're on the safe side. But there are studies that have been published. If you see pseudo progression, it may be indicated for a good response thereafter. But well, I mean, it remains difficult to give you one answer. It depends on the study protocol.
And depend on the solid tumor, which is the or
I think
lung
he's talking
cancer
about clinically.
Clinically.
Yeah, so
Yeah, the problem is that in our country we do a staging PET scan and not a standard PET scan during follow-up, only when there is an indication and when there is doubt about response or whatever. But nowadays, I mean, a CT scan is cheaper than a PET CT scan, so that is the reason why the clinicians ask for a CT scan and they say, okay, we see a good response, that's it. But if there is doubt or there are tumor deposits that do not show any response, they want to know what the tumor metabolism will be like the GIST tumors. If they give Gleevec, you won't see any response on the CT scan, but you want to know what's going on, and then we do a PET scan. But it really depends on the tumor and the clinical results.
Because sometimes in my oncologist radiation, consult about the PET CT result, they doubt the SUV uptake is because the radiation. So they often ask to what time the best to take the PET CT without inflammation after radiation is still exists.
Yes,
What is the real time? There is no inflammation from radiation.
yeah, so we wait at least 4 weeks after radiation. We wait at least 4 weeks. It sometimes takes longer, but 4 weeks is our sort of minimum.
Minimal 4 weeks after. Thank you, Prof.
Yes, Prof. Natenso, I have several questions. Could you please maybe later re-explain about the RECIST? You show us a table and there is like a target and then non-target. What do you mean by non-target?
So non-target lesions are lesions that are still there, but in RECIST you've only chosen 5 targets. So if you saw that that example, there were multiple liver metastases, but I only chose 2.
Okay.
The others are called non-target because I'm not targeting them for future follow-up.
Oh.
I just want to know what happens to them over time. But that's part of the RECIST criteria for reporting of research studies. So we choose 5, maximum of 5 target, the rest are non-target.
Okay, so the non-target is likewise, is it has to be the same lesion, the non-target as the first baseline PET?
Sorry?
The first from the non-target lesion?
Yeah, so you can choose as many non-target as you want. It depends how much time you want to spend. But you can choose 2, 3, 4, 5 non-target. You follow them over time, but you don't measure them. You just say, are they there, not there, not there.
Okay.
So it gives you a better overall picture of what's happening.
Okay, so thank you. The next question is, you mentioned about the NEMA test. So in PERSIST, if we do not do the NEMA test, then basically we cannot do PERSIST.
Well, you do. When you qualify your PET scanner, you'll do NEMA testing initially. You'll do quality control most days. In fact, there's automatic quality control. So within your camera, you can do your own PERSIST. But if you want to do a multi-center trial, then you have to do, as Professor Stokel said, you need to validate all the cameras that are on that trial. But within your own camera, you should be able to do your own PERSIST.
Okay. And then in the few first previous slide, you said that we use SUV peak.
SUV max, SUV peak.
SUV max. But in the a few last previous slide, you show that SUL peak. Which one did we use?
So we routinely use SUV. Well, actually, we use SUV max as our because it's easiest.
Oh, okay.
But it's usually a volume measurement
Mhm.
of the SUV. So
So
it also depends on whether we're using it from a trial point of view or whether we're using it internally.
Oh.
Because from a trial point of view, they may even stipulate exactly what they want. So, for instance, we're involved in a trial at the moment, and they want so many. The pixel size has to be X amount by X amount in 3 dimensions. So it's got to be a circular volume within the lesion, and that's how you work out what your SUV of that volume of that sphere is.
Okay.
But that's for a trial. When I'm doing it clinically,
Yes,
I don't do
SUV
that.
max.
I just use it. It's quicker. It's easier. It's what we do all the time, and by and large, it is reproducible.
And then continuing Dr. Bambang question for different cameras and without standardization, like Protocol said, what is your opinion if we use MTV, comparing MTV and not SUV?
Well, I think I'm not sure if that's been validated to the same degree. So it all depends on how you're also doing your MTVs. So is that on an automated program? It
Yes,
must
it's
be.
usually ISO control, right?
Yeah. So if you're now looking at different cameras, different results, it's not something that is a standard and may become a standard. We use a lot of tumor volume in our own internal reporting, but to look at someone else's results and then try and determine their MTV from a different scanner and comparing them to yours, I'm not sure if that. I'm not sure how valid it is. It might be, but I'm not sure how valid.
Thank you very much, Prof. Nathan.
Okay, thank you, Professor Nathan. So please give applause to Professor Nathan. We move to the next speaker, already well-known, very famous in Indonesia, Professor Marcel Stokkel. Please, time is yours, Professor.
Good morning to you all. It's a great pleasure being here again. I think twice a year, 3 times a year, I will be in Indonesia to meet you, to give lectures. And well, at least I enjoy it very much. It's the first time here on Borneo, Samarinda. The weather is not so good as I'm used to have in Indonesia. Normally on Bali or whatever, it's much better. But apparently it's a rain season, and well, that's the way it is. But nevertheless, I enjoy it very much. We discussed in the previous lecture the value of the RECIST and the PERSIST criteria. And you know that's really it's very difficult topic. Oh, yeah. What we nowadays use in clinical practice, and Professor Lenzo already explained, is that the SUV max is just common clinical practice. It's easy to do and it's easy to handle. What we normally do in melanoma patients, and we know that the tumor burden is much more of prognostic value than the SUV of one lesion. So what we nowadays use is a computer program to measure the SUV uptake in all the lesions, the MATV value, and to find out what's going on during therapy. But it is not established yet, but hopefully the publications will be accepted in the upcoming year, and then we can go ahead. Well, in the next 30 minutes, I will give a brief introduction into these standard selection criteria in theranostics, and in fact it has all to do with the PET scan, the pre-therapeutic PET scan, but there are more criteria you have to take into account before you can give radionuclide therapy to patients. I'm a nuclear medicine physician working in Amsterdam in the Netherlands Cancer Institute. I'm also dean of the academy there. Since a year, I'm also responsible for the high flux reactor, the medical isotope program in the Netherlands. There is now a new reactor under construction, and they asked me as consultant to give them advice how to move on with that. I'm also consultant working together with the Siloam group. It's really, well, grateful. I enjoy it very much. We have quite often discussions Monday, Tuesday, Wednesday morning, early in the morning. We start with the difficult cases to discuss what it is, what we're looking at, and it's really nice. And finally, I'm also an expert reader of the EIA. Does it work? Yeah. Well, this is in fact the outline of my presentation. Some practical aspects. Where do we come from? Where do we go to? Some predictive and prognostic factors I will mention. Some responsibilities in clinical practice when you're going to do radiopharmaceutical treatment. And finally, I will also say something about discharge and how to do the follow-up. And of course, one of the most important questions is, and that is in fact related to the therapy, what about dosimetry? We discussed the SUV values in the PET scanning, but what about dosimetry and the uptake related to the radionuclide therapy? Well, when we talk about radiopharmaceutical treatment, it's either PRRT or PRLT, but I know nowadays, I learned from the American Society that we have to talk about RPT, the radiopharmaceutical therapy, as a general name. What we know is that there are some effects we are aiming for, and one of the most important one is, of course, that we want to cure patients with the radiopharmaceutical therapy. But whether you use lutetium PSMA or lutetium dotatate or whatever, cure is not possible yet. And you have to realize that the treatment, the nuclear medicine therapy in that respect, is not a method to cure patients. But what do we achieve with the radiopharmaceutical therapy? Well, the most important things are stabilization of disease and reduction of tumor volume, and that has all to do with the quantity of life. So what you want to achieve is to improve an overall survival, or at least a progression-free survival with your treatment. That is the aim of the therapy. Reduction in tumor volume and symptomatic relief, well, that has all to do with the quality of life, and especially in neuroendocrine tumors, those patients who have symptoms like palpitation, diarrhea, flushes, whatever. Well, you hope to solve these problems and to minimize these symptoms. So symptomatic relief is one of the aims, one of the goals in radiopharmaceutical treatment in neuroendocrine tumors. But again, you have to realize that cure is not possible yet. Now, when we talk about the indications and patient selections, well, you have to realize that all these factors are related or coming from the NETTER 1 and 2 trials. And what we know from the randomized controlled trials is that symptomatic relief is achieved in about 75 to 80% of the patients, so that is really a good result. What we know is that the progression-free survival overall is in a range of 2 to 3 years. That is also good news. But what we know from the latest publication is that the overall survival is not more than 11.7 months in neuroendocrine tumors. And it has been stated that it was not clinically significant. So that was really disappointing. So after all these studies and all these years of waiting, they found out that the overall survival benefit was not clinically significant. But the last sentence in the summary was, it might be clinically relevant. So that is completely different from significant. The problem is that we're not there yet, but based on these studies, we have in fact established current selection criteria for radiopharmaceutical treatment in neuroendocrine tumors. Another important thing is what we know nowadays is that after the first courses of radiopharmaceutical treatment, it is safe to give a second treatment scheme. So you can retreat patients again. Patients undergo 1, 2, 3, 4 courses of therapy. Then you usually wait and stop. And if there is progression again, you can safely do a retreatment. But you have to realize that all these selection criteria in clinical practice are based on these studies. Now, what are current indications for the PRRT? And then we talk about the selection criteria for PRRT in neuroendocrine tumors. Well, nowadays in the Netherlands, what is reimbursed are the grade 1, 2, and 3 neuroendocrine tumors. That is easy. So irrespective of the tumor grade, it is reimbursed. And as long as the uptake is good, patients can be a candidate for PRRT. What is not reimbursed yet, but that is really a topic of discussion in our country, are the neuroendocrine carcinoma, the highly aggressive neuroendocrine tumors. Esthesioneuroblastoma, awful tumor types, and you can see here an example in the screen, 2 patients with esthesioneuroblastoma in the face. They are also regarded as neuroendocrine tumor types, having good uptake of gallium dotatate. And the question is for the insurance companies, is it now time to give money to treat the patients with PRRT? Also, the lung neuroendocrine tumors, small cell lung cancer may show gallium dotatate uptake. And nowadays, patients may be a candidate, but it is still not reimbursed yet. And a final tumor type that can be candidate for PRRT are the Merkel cell tumor, skin tumors. And they are a bit lookalikes melanoma. They behave like melanoma. They show a very good gallium dotatate uptake. And if the uptake is really, really good, patients with Merkel cell tumors may be candidates for PRRT. But the problem again in our country is that it is not reimbursed yet. But hopefully at the end of this year, all these new indications are not a topic of discussion anymore. So we're really looking forward to the final decision at the end of the year. Now, when we start talking about screening for PRRT, well, in fact, we start talking about the somatostatin receptor expression on the neuroendocrine tumors. It's quite easy and simple. It is that one that we use for patient selection. And you see here on the right side, is there something? Yeah, there it is. You see here 2 examples. The right one, a patient with a neuroendocrine tumor showing intense uptake on the gallium dotatate PET scan. What we know is uptake is higher than in the liver. It is a candidate for PRRT. And then you see here what can be seen after the first PRRT therapy. If there is no uptake at all, and you see a patient here on the left side, you have to realize that you can give PRRT, but there will be no response at all. So if the uptake is minimal or there is no uptake at all, these patients are not candidates for PRRT. Now, what is the optimal strategy? What we do nowadays is that we need at least a gallium dotatate PET scan not older than 3 months. So the PET scan, the gallium dotatate PET scan should not be older than 3 months. You're on the safe side when it is 1 month or 2 months old. If it is older than 3 months, you have to redo the scan to find out what the uptake will be. What is the problem if the PET scan is older? What can be the problem? What is the... Do you know what the problem can be? Sorry? Dedifferentiation. So the longer you wait, the higher the chance on dedifferentiation. So be aware that the PET scan should not be older than 3 months. Now there is a lot of discussion about the FDG PET scan in neuroendocrine tumors. In our country, we don't do the FDG PET scan unless there is doubt about the lesions. Is there uptake? Is the uptake minimal? What is happening? I know that it is different worldwide. There are countries who are doing dotatate scan followed by an FDG scan. Now, what can be an indication for the FDG PET scan? Any idea? It has prognostic value, the FDG PET scan. So you have to realize that when the uptake of the dotatate is low or minimal, you want to know what the FDG uptake is. And the higher the FDG uptake, the poorer the outcome will be. So FDG PET scan in neuroendocrine tumors is a real indication of prognosis. We don't use it as a routine procedure, but one of the most important indications in our country for an FDG PET scan are the higher grade neuroendocrine tumors or the neuroendocrine carcinoma. You want to know what is going on. Well, at least you need a contrast enhanced, oh, can I go back? Yeah, a contrast enhanced CT scan, not older than 2 months. And finally, of course, the blood tests. So again, the FDG PET scan, it has predictive and prognostic value, but the real additional value in the grade 1 and 2 tumor types is not really established yet. Well, here you see what happens, and that was in fact one of my first questions. On the left side, you see the differentiation grades of the neuroendocrine tumor types, low, intermediate, and the high neuroendocrine tumors, the de-differentiated tumor types, and the neuroendocrine carcinomas. And you see, when it is green, the uptake of gallium dotatate is usually high, but the more aggressive the tumor type is, the higher the differentiation grade. The chance of having lower uptake of gallium dotatate and an increase of FDG increases. So be aware that the more aggressive the tumor type is, the lower the uptake can be of the dotatate and the higher it can be of the FDG. Here you see some papers that have published the prognostic value of the FDG PET scan, and you see here 2 examples. This one with a low uptake of FDG against a high uptake, and you see here also in this paper, the FDG PET scan has really prognostic value. But again, in grade 1 and 2 tumor types, we don't use it, and only when there is doubt about lesions that have minimal uptake. What are the contraindications for PRRT? Well, in fact, it's quite simple. A life expectancy less than 6 months. And why is that, a life expectancy less than 6 months? What is the explanation for that? Yeah, it takes some time before you have some effect of the PRRT. We give 4 courses of PRRT, and it is not just a way. It takes that time to get a response, an optimal response. And with an interval of 8 weeks, 4 times 8 weeks, well, if the prognosis is less than 6 months, you run out of time, in fact. So, of course, unacceptable medical or radiation safety risk for isolation. It is an inpatient treatment, but when there is a risk of myocardial infarction or whatever, fracture risk, we don't give the therapy. That has to be settled before we give the PRRT. We have to be on the safe side. Of course, pregnancy, but usually we treat patients older than 45 years, 50 years of age. So that is usually not a problem. There may be some aggravation conditions, unmanageable urinary tract obstruction or hydronephrosis. If that's really a problem, solve that first before you give the PRRT, because if there is an obstruction, an outflow obstruction, it may really destroy your kidney function. Previous myelotoxic chemotherapy or radiation therapy may be a relative contraindication, but when the interval is more than 6 to 8 weeks after chemotherapy, you're on the safe side. And also, pending liver failure, it is really an absolute contraindication for PRRT. There are some laboratory tests you have to do. HB less than 5.5. Now, if it is around 5, and that is the only parameter, blood parameter, that is diminished or decreased or too low. What is the solution of a low hemoglobin level? Give just a simple transfusion prior to the PRRT. You're on the safe side, and usually thereafter there's no problem. However, when it is combined with problems with platelet value or white blood cell counts or whatever, yeah, then you have to think about whether to move on or not. And these are really absolute values you have to take into account. So when the platelets are below 75, don't give the PRRT. When the absolute white blood cell count is below 2.0, don't give the PRRT. Also, renal function tests, be careful. When the glomerular reflection rate is below 30, well, don't give it. You will really destroy the renal function. Patients run into problems. When it is below 50 but higher than 30, well, you may think about it, giving PRRT. And if there are no other problems, so when bone marrow is okay, when there is good uptake of gallium dotatate in the tumor lesions, you may give PRRT. The only thing you have to take into account is that you may lower the dose. So instead of giving 200 millicuries or 7,400 megabecquerels, you can lower the dose depending on how severe the renal function is diminished. And finally, the liver function, take that into account. Well, there are some predictive factors, and predictive factors means that you want to predict the response to PRRT. It's not a prognostic value, but it is a predictive value. Will the patient respond or not? Well, what we know, in fact, that it is all related to a low tumor uptake of the radiolabeled dotatate ligand. And what we know nowadays, for example, is low tumor absorbed dose during PRRT, the low SUVs on the gallium dotatate, the SUV-max changes prior to and after PRRT. It all correlates with the predictive value. Inflammation in neuroendocrine tumors. There are some other parameters you can take into account. We don't use these parameters to select patients. It has only predictive value. And finally, again, we have to realize the presence of viable FTG positive but dotatate negative tumors is really, really a good indication of response prediction. There are some prognostic factors related to PRRT. Well, again, we talk about the presence of viable FTG positive but dotatate negative tumor lesions, and the Ki-67 labeling index is also a problem. Or a prognostic factor. But from this report you can see, it was published in 2021 from the Italian group, there is a lack of prognostic and predictive factors in PRRT. However, the only parameter that can be used for response prediction is the FTG PET-CT scan. But all other parameters are still not really used in clinical practice. Well, there are some precautions prior to start of the PRRT. There is a discussion about the somatostatin analog withdrawal. Do patients have to stop or not? We have published a paper about this, and what we know is that normally when we do a gallium dotatate PET-CT scan, patient had to stop the somatostatin analogs. But we have proven that there is no need to do that. So patients can continue by using that. And even, and that is hopefully it will be published this year in the therapeutic setting, there is no need to stop the somatostatin analogs. So patients can use their somatostatin analogs, and that's it. Of course, renal protection, the amino acid solutions that have to be applied. Oh, what's happening? Oh, magic. You have to give the amino acid solution. It should start 30 to 60 minutes prior to the PRRT, and it should be continued for 4 hours. Antiemetics that can be given shortly before the amino acid infusion. And why do we give antiemetics? It is not because of the lutetium dotatate. it is because of the amino acids. They cause nausea and vomiting, but not the PRRT itself. You have to realize that PRRT is an in-house treatment, and the only indication for that is because of the neuroendocrine hormonal crisis. In our clinical setting, we have never observed it, the hormonal crisis. So PRRT is in fact, if you use a proper screening setting, it's safe. You can do it. But use the proper selection criteria. The hormonal crisis usually occurs within the first 24 hours. So that is the reason why it is an in-house treatment. But I think next year, if we still keep on using the proper selection criteria, it can also be like lutetium PSMA, an outpatient treatment. Well, here you see, and I give you the handouts, of course, what to do in case of a hormonal crisis. Well, you have to give somatostatin analogs, corticosteroids, etc., etc. But that's just common clinical practice. Now, the standard protocol is quite easy. You give 4 courses of lutetium dotatate with an interval of 8 weeks and a standard dose of 200 millicuries. So that is easy, but it all starts with a proper selection, a proper patient selection using the gallium dotatate, PET-CT scan, and blood test, as well as a contrast-enhanced CT scan, and that's it. Well, we use nowadays lutetium dotatate. There are some centers that use yttrium dotatate. Be aware that the activity is much lower with yttrium, and the interval and the number of cycles is different from lutetium. We also can call it PRRT, but it is a different treatment scheme. Be aware of that. Now, one final comment. What about cardiac metastasis? Sometimes we see metastatic disease in the myocardium. And we recently discussed the case from your hospital, what to do with it or not. Can we give therapy or not? In general, myocardial metastases are not a contraindication for PRRT. Side effects related to the uptake in metastatic disease in the myocardium have not been published or not reported. So it's safe, not a problem at all. And you see, we published a paper, Cardiac Neuroendocrine Tumor Metastasis, a review of literature, and it turned out that all these patients with metastatic disease in the myocardium can safely be treated. It's a clinical setting. This is the clinical setting in our hospital. We give it, it's a slow speed intravenous administration. It takes 20 to 30 minutes. You want to avoid cardiac symptoms. If you give it like a bolus injection, really patients will notify it. They get palpitations, flushes, whatever. So take your time to give it. Again, patients have to stay one night, and the day thereafter they go home. And there is a lot of discussion about dosimetry. Normally what we do, or what we did, was a scan, a post-treatment scan after 4 hours, 24 hours, and a week. But nowadays we do only one scan after 24 hours after the first and after the last course to avoid really a time-consuming procedure. So dosimetry is not common clinical practice in our hospital, although it's recommended by the ANM and the Atomic Agency. Be aware of that, but it is really time-consuming if you want to do dosimetry. Now, some final comments and some differences with the RPT in prostate cancer. In fact, all the recommendations and all the guidelines and the selection criteria are based on the FISION trial. And also, you have to realize that the FISION trial, we know that the progression-free survival is good. We're still waiting for the overall survival results. Be aware that in general, the results are not as good as in neuroendocrine tumors. So the radiopharmaceutical treatment outcome is not yet as good as related to the FISION trial or described in the FISION trial. When we talk about PSMA and the theranostics concept, one important thing is that there are so many PSMA ligands available, but there are only nowadays 2 or 3 on the market that can be used for therapy. The most commonly used is PSMA INT and the PSMA 617, and the 617 is produced and delivered by Novartis. In most hospitals, when you do an in-house labeling, we use INT, or INT is used. In fact, they are comparable. They have the same results, the same uptake patterns. So, irrespective of the ligand used, you will achieve the same clinical outcome. Now, what about screening for PSMA treatment? It's a prerequisite for success. Well, one of the most important things is that you need a recent PSMA PET-CT scan not older than 2 months. For neuroendocrine tumors, it was not older than 3 months. What is the difference between that? Why can we accept 3 months for the neuroendocrine tumors and 2 months for prostate cancer? I heard something about progression. Yeah, the doubling time usually of prostate cancer is much higher than of neuroendocrine tumors. So if you want to treat patients with radiopharmaceuticals, you have to speed up your program, hurry. So do your selection criteria or check them within a certain time span. In neuroendocrine tumors, you have the time. You can discuss it with the clinician. Once the patient is referred for treatment with prostate cancer, speed up the program. Also, recent blood tests not older than 1 week, and a contrast-enhanced CT scan not older than 2 months. A renogram may be required, but it is not as important as in PRRT. So for radiopharmaceutical treatment in prostate cancer, of course renal function is important, but not as important as in PRRT. Well, what do we know about the selection criteria? They are all based on the VISION trial. At least the presence of PSMA positive lesions defined as PSMA uptake greater than that of the liver parenchyma in 1 or more metastatic lesions of any size in any organ. That's the definition of the most important selection criteria. So what are PSMA negative lesions? Well, then you may deal with 3 different topics. A lymph node with a short axis bigger than 2.5 centimeter with an uptake lower or equal of that in the liver. Metastatic solid organ lesions with a short axis bigger than 1 centimeter, and any metastatic bone lesion also with a size bigger than 1 centimeter. If the uptake is equal or lower than in the liver, it is a contraindication for radiopharmaceutical therapy. So patients with any PSMA negative metastatic lesion are ineligible for PRLT. What is the reason for that? Any idea? All those lesions that do not have any uptake will show no response, and they are in fact the prognostic factors. And it is really different from the neuroendocrine tumors, but you may have tumors with low gallium dotatate uptake and with some FGG uptake. What we know is that despite the FGG uptake, the prognosis in those patients who have been treated with PRRT is much better than when not giving them. And that is completely different in prostate cancer. So if you have negative uptake or minimal uptake, don't give this treatment. That is, in fact, according to the VISION trial. Patient-related contraindications, life expectancy is less than 3 months. That's completely different from the neuroendocrine tumors, which was 6 months. Be aware of that, it is different. So don't use the same selection criteria. If the life expectancy is less than 3 months, don't give the PRLT. What is the reason for that? The time of response is too long. Yeah, I mean, tumor progression may occur while waiting for any response related to the first course. And of course, the interval is around 6 weeks. And then 6 weeks later, you give the second. So you will lose the battle. Medical or radiation safety, risk for isolation. Well, in fact, nowadays it's not really a big problem. We give an outpatient treatment. So patients come to the ward, they get the PSMA administration, they have to wait for 4 hours, empty the bladder, and can go home. And that is different from the neuroendocrine tumors. And the most important difference is that you will never observe any side effects during hospitalization. And that's a completely different from the neuroendocrine tumors. Of course, progressive deterioration of organ function when the glomerular function rate is less than 30, that is comparable to the PRRT. If the kidney function is too low, be aware that you may destroy the complete function of the kidneys by applying radiopharmaceutical therapy. Myelosuppression, that is also in agreement with the PRRT. If you have a platelet count less than 75 or a total white blood cell count less than 2.5, don't give this type of treatment. Really, you run into problems and you get awful toxicity. And also conditions which require timely intervention, like spinal cord compression or unstable fractures or whatever. If that is really a problem, treat that problem first and then schedule the patient for PRLT. There are some predictive factors. What we know is that a low uptake, tumor uptake of the radiolabeled PSMA ligands, if the SUV is low or the tumor to liver ratio is too low, we know that there will be no response to the PRLT. The presence of viable tumor deposits and negative lesions, in fact, that is a contraindication for PRLT. What we know is a PSA decline of at least 30 to 50% is predictive, and that is indicative of a good response. When it is less than 30%, you know that you run into problems, and the next, you have to think about the next treatment course, whether to move on or not. So PSA decline is really a good indicator of a good response to treatment. One of the discussions about the uptake, the PSMA uptake, is what should we use? Well, at least use the liver as standard organ, compare the uptake in the lesions with the liver uptake. You see here examples. The left one, you see high uptake, where the uptake is much, much higher in all the lesions compared to the liver uptake. You see here intermediate uptake. Most of the lesions have higher uptake than in the liver, but you see there are some small lesions. Well, it seems comparable, but that might have to do with the size of the tumor. So the smaller the lesions, the lower the uptake can be. So be aware that you have to compare the lesion size and account that for, take that into account. And here on the right side, you see the low uptake or no uptake. There are some lesions in the skeleton, the irregular pattern there. Be aware that if you see an uptake pattern like that, don't give a radiopharmaceutical treatment. There will be no response at all. There are some prognostic factors, well, in fact, comparable to the neuroendocrine tumors. We know that age, an ECOG score of 2 or 3, symptomatic patients, when they have severe pain, bone pain, high Gleason score, and a short response to hormonal treatment, their prognosis in general is much worse than when this is not present. Imaging findings, when there are visceral metastases in prostate cancer, the prognosis is poorer. The presence of bone metastasis, and patients with bone metastasis have a much poorer outcome compared to the patients that have only lymph node metastatic disease. So be aware of that the site of lesions is also of prognostic value. And finally, of course, and that has something to do with the total tumor volume, the larger the tumor volume will be, the poorer the prognosis in general will be. The treatment procedure is in fact quite easy, 4 to 6 courses with an interval of 6 weeks, and also a standardized dose of 200 millicuries. Sufficient hydration should be applied. Prophylactic antiemetic therapy, well, it is permitted but not really required. And I told you that antiemetic treatment for prior to PRRT is not related to the lutetium dotatate, but it is related to the amino acid infusion. So also for lutetium PSMA, it is not really required. And compared to PRRT, you can use a high-speed infusion. So within 2 minutes, 5 minutes, you can give lutetium PSMA. You're on the safe side, and that's it. So completely different from PRRT. Again, a clinical setting. We give lutetium PSMA on our therapy ward, an IV administration. It's a full automatic system. You see here the device we use. It's quite nice. That is the device where the syringes are put in. Here is the computer. We press on a button, enter, and within 1 or 2 minutes, you get a complete infusion. And shortly thereafter, also there is a flush with saline, and that's it. Again, there is a discussion about the follow-up scans, dosimetry. We don't do it as a routine procedure. We make 1 scan after the first course, after 24 hours, and a second scan after the 4th gift, and that's it. And we don't calculate any uptake. We only want to assess that the uptake is good after the first course and after the 4th course, and that's it. Well, the side effects, well, in fact, comparable to PRRT, you may expect hematological side effects, the acute hematological toxicity, and also acute loss of renal function, but usually this is not observed in our population. When you do a proper screening, you will not observe these side effects. The non-hematological side effects may be observed: fatigue, toxicity, gastrointestinal toxicity, but it is really never of grade 3 or 4. It's usually only grade 1 or 2, minimal. Skeletal adverse events, well, sometimes patients may notice some more bone pain, but it will resolve over time, and if required, give pain medication. What might be expected is dry mouth because of radiation damage to the salivary glands, but we have never observed it. So when the patients are in a good condition, you are on the safe side, and we have never seen it. It has been reported in literature. However, the more courses of PSMA are given, the higher the chance of getting a dry mouth, and again, flare-up related to tumor-related pain in the bone. Now, finally, this is our team, which is responsible for every part of the treatment. We have an oncologist on board, the multidisciplinary team, and in fact, he starts with a proper patient selection. And the first question is, has the patient got all hormonal treatment therapies that are available, or chemotherapy, or combination treatment? And if the answer is yes, then the patient is referred for the radiopharmaceutical therapy. We have the nuclear medicine physician. We do the intake, the prescription. We are in fact the supervisors of the whole procedure. We have physician assistants. They give the therapy. So we as a nuclear medicine physician are not in the room when radiopharmaceutical therapy is given. They do the follow-up, and when there are problems, they call us. We have physicists for the dosimetry and uptake quantification. Of course, the radiopharmacists for the labeling procedures. Technologists, they do the PET scans and the post-treatment scintigrams. We have nurses, especially important for the neuroendocrine tumor therapy. They do the intake and the general checkup. And finally, we have therapy planners. They do the coordination, and in fact, they are responsible for the whole workflow. And that is our team in our hospital. Of course, one comment, we know that in literature there is a lot of discussion going on about alpha radiation, how to move on, and do we get better results compared to lutetium, the beta irradiation. What we expect is that the DNA damage related to alpha irradiation is much higher. So the overall outcome related to alpha therapy is expected to be better. But we still have to prove that. And when there is no uptake or minimal uptake or slight uptake in lesions, for example, on the dotatate scan or the PSMA scan, it is now regarded as contraindication, but it might be not a contraindication anymore when we talk about alpha irradiation because of the power of alpha therapy. Well, we're really looking forward to the first results in literature, and you have to realize that what I say now, next year it may be completely different when we have the results of all these studies. So times are changing. Another important thing is that when we give lutetium PSMA therapy, in fact, we give it as a third-line treatment option. Patients come, they get hormonal therapy, then they go to the second-line treatment, and then, if it all fails, patients are referred to our department. But now, some of the patients are referred to us when they have cancer at an earlier phase. But we're still waiting for the randomized controlled trials, what the effect will be of lutetium PSMA, or lutetium dotatate given at an earlier phase. So the comparison, the studies that compare docetaxel with lutetium PSMA, they're really promising. And one of the advantages of our treatment options are less side effects compared to chemotherapy, but we're still awaiting for the prognostic outcomes. So some recommendation: follow strict selection criteria, organize a multidisciplinary team, and especially establish who is responsible for what part of the therapy course. So also the oncologists should be on board. Be aware of side effects. In PSMA, it is minimal. For neuroendocrine tumors, it can be a hormonal crisis, but the risk on that is extremely low. An FDG PET scan is not really required unless a treatment, it usually takes 4 to 6 courses, so be aware that the ultimate effect is established after, well, at least a year. We know that the first or 3 courses are important, but the final effect is established after 4 to 6 courses. Cure is not achieved. Explain this to the patient because they think that they will get a curative therapy. And nowadays, it is not possible yet. And of course, one final comment, dosimetry is recommended, but not more than a good estimate after therapy. It is of predictive value, but it is really, really time consuming. So think about it, what to do with it. But at least 1 or 2 scans during the whole course to assess the uptake of lutetium PSMA or lutetium dotatate is highly, highly recommended. And I think this was the last slide. Yeah. Okay, thank you very much.
Thank you. Please give applause to Professor Stocker. So because we are running out the time, I limit the question, only 1 question. Yes, Bang. 1 quick question, please.
The reduce of the dose, because if we wait the patient until the blood count is good enough, we don't have time. Have you considered the reduce the dose from the 740 megabecquerel? Because in our department we use MIBG, iodine. The patient is still in myelosuppression. The hemoglobin and leukocyte is not optimal enough, so we reduce the patient. The patient must be given 100 millicurie, but I just give them just 50 until 75 millicurie. How about the PRRT? Have you?
Yeah, well, there are two strategies, what to do when there is toxicity. Well, the first one is postpone your treatment. So you can wait, and unless you see some recovery of the blood tests, if there is no recovery at all, you have to be aware that there is something going on. And especially in prostate cancer, if the blood tests do not recover anymore or show any recovery anymore, you have to be very careful by giving the next one, or even with a lower dose. Another strategy is that when you see some recovery of the blood test, we usually halve the dose. And the problem is by giving a much lower dose, so 50 millicuries or whatever, I think patients are undertreated. So the optimal dose is not achieved with that. And be aware that a suboptimal dose, I think it should not be a standard strategy. So either postpone it, wait until see any recovery, and if you don't see it, be aware that there is something wrong with bone marrow.
Because in practice we have pesan apa obat itu. We buy the medicine 1 week before the admission the patient, but at the end of the day the complete blood count is drop because we pesan obat itu 1 bulan sebelumnya maksudnya. We order the medicine 1 month before, but 1 week before the therapy, the complete blood count is drop.
That is with MIBG.
Yes, for MIBG. So
we know that with MIBG it can be it takes some more time, but we know especially for in neuroblastoma it may drop after 3 to 4 weeks, but that is also comparable to radioiodine therapy. Sometimes you see a decrease in the values after 3 to 4 weeks. And at that time point, when you see really a decrease, you don't know what the nadir will be, what the lowest value will be, and when it is reached. So if it goes down and you see that it is really a decline, be aware that you may run into problems when you give treatment the day thereafter. That is not what we do in our hospital. Postpone it. Maybe you have ordered already the MIBG or whatever, but don't give it if the blood values drop.
Okay, so don't take the risk.
Don't take that
risk. Or you already have the drug, so you can waste it.
You may have. Yeah.
Okay.
We started using it in 2014 in Australia. That's the PSMA molecule, and there is a number of different agents that bind to this molecule. It's a transmembrane molecule. We're swapping over. And there are multiple binding sites for the imaging and the therapies. That's what gallium PSMA looks like as a molecule. And most people in Australia who use gallium PSMA use a generator and now the Telix kit. What is PSMA? It's actually a transmembrane glycoprotein for folate hydrolase. So why is that important? Because the cancer cells have upregulate folate metabolism. So to survive, they need more folate. So often you'll see cancer cells increasing the expression of this gene, the FOLH1 gene. It's not specific for prostate cancer. We see it in other cancers. We see it in some renal tumors. We see it in some thyroid cancers. We see it in glioblastoma. But it's highly expressed in prostate cancer. The higher the Gleason score, the higher the prostate cancer. Very overexpressed in prostate cancer, but you'll see it's also present in the small bowel and some other organs such as the salivary glands. And this is sort of a standard, what a normal PSMA PET scan looks like. We have normal salivary gland activity in the parotid glands and submandibular glands. We also get it in the lacrimal glands. Variable uptake in the liver. It's renally excreted, so we see it in the kidneys. I mentioned the small bowel. Folate hydrolase is present in the bowel. And then, of course, in the urine where it's excreted. The two most common traces approved in the United States is the gallium PSMA 11, known as Illuccix, which is owned by Telix, mostly distributed by Cardinal Health in the United States. Then Lantheus have Pylarify, DCFPYL. This is a comparison between gallium PSMA and Pylarify, very similar distribution. And this also shows similar distribution between gallium PSMA and PYL. There are other agents that show different distribution. So 1007 shows much more liver activity. It's hepatically metabolized, and it shows very little renal excretion. So these are the sort of common ones that are on the market. The PSMA, the gallium PSMA, the PYL, and now the RH-PSMA-7, which is owned by Blue Earth Diagnostics, are the only ones that are currently approved in the United States, and I think also in Europe and in Australia. The 1007 is not approved in Australia or the United States. So I mentioned it's higher in high-grade tumours, it's higher in hormone castrate-resistant disease, metastatic disease. There are 3 scenarios where we clinically use PSMA PET. So firstly is when we first diagnose PET as prostate cancer. So someone will present maybe with a high PSA or some symptoms. They will get an MRI. They will then, if the MRI shows suspicious lesions, they will get a biopsy. Some people go for a biopsy even without an MRI. Sorry, let me just... So the first setting is to try and work out if the disease has spread when we're first staging the disease. So in Australia, the current indications are if you have intermediate to high-grade disease based on a Gleason score, and you have a high PSA, then you will be eligible to get a PSMA PET scan to better stage the disease before the surgeon or the radiation oncologist decide to give you treatment. The second indication is someone's had surgery or radiotherapy, hopefully to cure the disease, but then the PSA starts rising. So biochemical recurrence. Where is the disease? So that is the second indication. You have a PSA rise after what was thought to be definitive therapy. And I'll quickly just go through the data, but there's a lot of data on PSMA PET compared to standard imaging, which used to be CT and bone scan. It's more accurate than standard imaging. We pick up disease much earlier than anatomical imaging. It's better than choline. And the higher the PSA in biochemical recurrence, then the more likely is that we're going to pick up disease. There have been a number of trials, the Condor trial, which looked at PYL, and this is a trial out of Australia looking that if we use PSMA PET in primary staging, we change management in about 20% of patients, and in biochemical recurrence, we change management in over 60% of patients. In radiotherapy, there's a change in radiotherapy planning in about 50% of patients. So these are the current Australian indications. So that's intermediate to high-grade prostate cancer where you're trying to stage initially, or in the setting of a rising PSA. And of course, the third indication now is pre-lutetium PSMA therapy, and which is this. So now the third indication for PSMA PET in Australia is prior to targeted radiopeptide therapy. So that's all I wanted to say. And just finally, I'm talking about PSMA PET, but there is interest in techie PSMA, and I know my colleagues at MRCCC have used this, and the technetium PSMA is actually not a bad agent, actually. And there's part of this registry where they're comparing gallium PSMA or to technetium PSMA, and they're showing some very good results. And well done, Dr. Rian, having the first patient in the Nobel Registry. Okay, so that's all I wanted to say as a background. Does anyone have any questions before we go into some cases? Yes. Well, the answer is they've got PSMA expression. They should be a candidate. In my country, the way they're written is for PSMA PET, but that's because the data isn't yet there for technetium PSMA. But theoretically, yes. I don't know in Europe.
Was a paper published, I think from Switzerland, where they did a study with technetium PSMA, and it turned out that it correlated much better with the lutetium PSMA uptake than the PET CT uptake did show. So, and maybe it has something to do with timing of the PET scan and the uptake after the injection, and etc., etc. So, I think it's a matter of time that we can also use technetium PSMA for that. The advantage is, I think it will become cheaper because gallium PSMA or the DCF pill, whatever, are really expensive when you buy them and not produce them yourself. And with technetium, well, I think it will be affordable or more affordable. And if we have a better correlation with dosimetry, I think we're there. And then we all move back quickly, I think, to the technetium PSMA, but it's all a matter of time. But we definitely need more studies. And the major problems and difference is that with technetium PSMA, I think that we'll miss smaller lesions compared to the PET scan, and that is the difference. So the resolution issue is not solved yet, but maybe that is why it is more correlative with the treatment option than the PET option.
Circumstance condition, because in Yogyakarta we can do TC-PSMA, but if the patient have positive, I will refer to Dr. Rian in MRCC Jakarta. So for treatment, for diagnostic, we can do it in Jogja for TC-PSMA.
Yeah.
So the consider is
Look, I think for treatment,
yeah,
particularly most of the patients will have extensive disease. So if you're missing one or two little lesions, it doesn't matter. So I think Techie is a very good agent.
And another indication of technetium PSMA might be image-guided surgery. So nowadays, especially in one of the academic centers in the Netherlands, they use technetium PSMA for lymph node detection during surgery. So they do a PET scan, and then shortly before surgery, they inject technetium PSMA, use the probe, a drop-in probe, and they find the lymph nodes and take them out, and that's it. So it's really, really impressive what's going on. But the most important thing is, do we improve overall survival with that? We don't know.
or not.
It's like a sentinel node, but it's in fact image-guided treatment.
Okay, I'm going to start with the first case now. So just to go through, so when I'm looking at the PSMA PET scans, I always look at the whole body MIP. You get a lot of information from the whole body MIP. Very important to also look at using different windowing. If you window down significantly, you can even see the renal parenchyma. Why is that important? Because occasionally you'll pick up a little renal cell cancer, because renal cells do often express PSMA. So you see I've wound down the renal, the contrast, and I can see the renal parenchyma quite nicely there. So this is an interesting case. I'll rack it up again so you can have a look. This is an interesting case because this is a gentleman who had intermediate grade prostate cancer, a moderately high PSA. MRI showed a PIRADS 4 lesion. So once again, I look at it in black and in white just to, sometimes you'll pick things up. So the bladder's there, the prostate should be sitting here, really not much to see. So if I go to my transaxial slices, And if we look at the prostate bed, what do you think? Low uptake. Okay, so the other thing that we always do, which I hope you guys always do as well, is important to have a look at it, the CT and the non-AC images. So it's useful to have the contrast racked up quite a lot to pick up very little fine things. And when we get into the prostate, even with it quite high, there's not a lot of activity here. So for those that haven't reported much PSMA PET, just to always important, look at the lung fields. You miss things if you don't look at the lung windows. And also very important to look at it in multi-dimensions. And to scale it way back, if you want to look for liver metastases, you need to scale it down, or else you will miss liver metastases. So low grade. Now, just for the sake of those that haven't seen too many PSMA PET scans, okay, what are we seeing here? What are these? Salivary glands. Salivary glands. You can see sometimes a little bit in the larynx. You may see some low-grade activity within lymph nodes. So inflamed lymph nodes can show you some activity. What can you tell me about this heart? What is that white thing? Calcium. Coronary calcification. I always mention coronary calcification. No use in saving the patient from his prostate cancer and dies from a heart attack. So I always mention if there's coronary calcification. It's actually a pretty good test to tell you what's happening. What are those things? What's that white thing? Cholecystectomy clips. So is that liver normal, PSMA? Looks normal, good. The spleen normal? Good. Now the kidneys, we looked at them in low grade. So you will see low grade, you will see activity in the small bowel. Once again, folate hydrolase. Metabolism. So you can understand why we see PSMA in the small bowel. It's also one of the problems with actinium PSMA, because it goes to the small bowel and causes an enteropathy. The bladder, and okay, low-grade activity. So sometimes, even though this was a Gleason 7 tumour, we don't see a lot of activity. That is actually not a bad thing, because as I mentioned before, the amount of expression is a marker of aggressiveness. So theoretically, this may be a low-grade, act like a low-grade tumour, even though it's a Gleason 7. I don't know if it was a 3+4 or 4+3, but it basically, you would hope that this means this is not an aggressive type tumour. Now, they wanted us to tell them about lymph nodes and everything like that. We can't see anything, but it's a low-grade tumour. But prognostically, this may be a good a good patient. So that was the reason I wanted to show that case. Now I'll show you another case. Where is it? Okay, so once again, PSMA. That's the MIP. Put it under. Anything abnormal that you can see? I hear focal uptake in the prostate below the bladder. Is it one site, two sites? Two sites, very good. Two sites on the MRI. So it correlates with what we're seeing on the MRI. And I will just so once again, let's go through this. What do we see here? Salivary glands, a little bit of uptake in the larynx that is normal. Sometimes you will get a little bit of low-grade activity in the thyroid. If you see focal activity in the thyroid, then you need to investigate that. No coronary or very little coronary calcification, that's good. Liver, that looks normal. Spleen looks normal. Kidneys, small bowel, going down, having a look, paraaortic lymph node chain, pelvic lymph node chain, bladder, and here we have it. Two sites correlate very well to what we saw on the MRI. So two sites of disease, no nodes that we can see. So once again, important always to correlate it. You will miss things if you don't look at the black and white. There is much better contrast in your black and white imaging than there is in your color imaging. So that's it. Too high to see anything or too bright to see anything. So let's lower it down. And always remember the lung windows. I saw a case recently where the patient had lung cancer, PSMA negative, and you only picked it up in the lung windows. And in fact, if you look at this case here, what do we see? We see a nodule. About a 6 millimeter nodule, maybe a bit less, maybe 5 millimeter nodule, not PSMA avid. You should report that in your study. Important that you pick up these incidental findings. Always look at the lung windows. The other windows that we also should always look at, and it's best to look at it in the sagittal, is of course the bone windows. You will miss things if you don't look at the bone windows. So this is a case that shows two sites of disease, high-grade prostate cancer. In this case, it was Gleason 8, PSA was 10, but it correlated very well with the MRI findings. Any questions about this case before we move on? Yes. Yeah, so if I'd say there's a 6 millimeter nodule. I'll see what lobe it is. So the size, the lobe, if it's got a spiculated appearance, there's anything, calcium or anything in it, then what I would usually say in this case is correlation with other imaging. Of course, if he's had previous CT scans, compare it. If it was there 5 years ago and hasn't changed, then it's unlikely to be of anything significant. But if it wasn't there 6 months ago, then that is significant. And then we just use the Fleischner criteria. So we basically say whether, you should get another CT scan in 3 months' time. I don't routinely, it's something like this, I wouldn't say do an FDG PET scan. Look at old CTs, if you've got them, or if not, repeat a CT scan at the designated time. So there are very standard protocols for lung nodules. You just follow that. Any other questions about this case? If not, we'll move on to another one. Let me have a look. Okay. This was also a staging scan. So this was a Gleason 8 on the left, Gleason 7 on the right, and they were worried about could there be a bone lesion on the MRI. I don't think we need an MRI to tell us what we see. Anything grab you? So we see something on the left, and in fact, that was the Gleason 8 tumour. Gleason 7 on the right, actually much more difficult. We do see a bone lesion, and we also see something in the rib, don't we? So we can confirm that. Salivary gland, larynx, liver, spleen, bowel, left kidney's gone, very good, and that. So that's definite metastasis. Gleason 7 on the right, Gleason 8 on the left. Are there any lymph nodes? Not that we can see. So occasionally you can get, question is that a lymph node or is that the ureter? That looks like it's ureter crossing over right here. Often useful to have a look at the coronals. Often you get a better idea of the ureters when you're looking at the coronals because they follow, you get that linear look down here when you're looking at the coronal. So yep, that's ureter. So this unfortunately is metastasized already to bone. But in our country now, even though there isn't a lot of data, if he has an isolated metastasis, they would be aggressive in the treatment of the primary prostate, and they'll be aggressive in the treatment of that oligometastatic disease. So it would If he was suitable for surgery, he would have surgery, he would have radiotherapy, and then he would go on to likely systemic therapy. So in the interest of time, because we are short of time this afternoon, I'll probably just go on to, we didn't look very good, but you would look at the lung windows. It's interesting though, the number of cases though where you get lung metastasis in prostate cancer isn't that high. Does happen. Let me just make this much bigger. There's a rib lesion. Yeah. Look, I would say it's likely a rib metastasis. In the setting, he's already got a big bone metastasis. So much less with gallium PSMA. Much less. In fact, in some places in Australia, if they do the fluorine and they're not sure, they go and do a gallium. Yeah, but I'll just call up the lung windows here. So gallium seems to have less of that, but the fluorine, particularly 1007, where am I? Wrong one. Lung. Once again, he's got a bit of a pleural reaction there, but no PSMA lung disease, no nodules. And I'll just call up, where is that? Come on. There it is. The rib lesion. And I'll just call it up on bone windows. Can we see it on the bone window? There it is. Right there. Let me call it up, make it bigger. Right there. So, partly sclerotic bone lesion. So he's gone from what was felt to be localized disease to stage 4 metastatic disease. So the last case before I get Dr. Sokol involved is, So this is a patient who's had therapy, who's on chemotherapy, and they want to see whether there's been a response to treatment. This is the old scan, and this is the new scan. Has there been a response? Just on this. Any thoughts? It's pretty obvious. So the humeral lesion looks a little less intense, as does the rib lesion. And in fact, those are the two areas that were treated with radiotherapy. Well, actually, the humeral lesion looks less, the rib lesion doesn't. So this patient had treatment of the rib and the humerus with radiation therapy. But unfortunately, he's now had progressive metastatic disease. So if I call up his fused images, so that was the rib, that's the rib lesion there. Oh, sorry, the humeral lesion. So partial response, you'll see some activity that might be inflammatory post-radiotherapy, but it's also, it could be just motion artifact that you see it outside of the bone. The lesion there was, I believe, also present previously. And now has got a left acetabular, superior acetabular lesion which wasn't there before. And also a subtle lesion which was there before. So partial response in the areas that were treated, but new disease. So progression on persist. And I won't go through the other lung windows and so forth. There wasn't anything else found, but I'll leave it at that. Any questions on PSMA PET? Yes.
Has higher sensitivity or?
So I should have made that a bit clearer. If someone uses PSMA 1007, is that what you use here? Yep. 1007 has a lot more benign bone lesion uptake. So significantly more. So one of the problems, and I imagine that may be one of the problems why it's not actually approved in the United States. I don't think it's approved in Europe, is it? 1007? It is approved? So it's not approved in the United States, it's not reimbursed in the United States, it's not approved in Australia, it's not reimbursed in Australia. The other agents, Polarify and gallium, which is a fluorinated agent, and gallium PSMA 11, which are both approved, they don't have the same bone issue. The RH7, which is the, can't remember its trade name, but it's the Bracco Blue Earth Diagnostics compound, which is also approved in Europe, the US, and about to be approved in Australia. That doesn't have as many bone issues either, but the 1007 has a lot of bone issues, and so you could see something which theoretically could be called a metastasis. So for instance, that case we saw, 1007, if you saw that on a fluorine, you'd say, oh, maybe it's just a benign bone lesion. But if I see that on a gallium PSMA, particularly in that clinical scenario, that's a metastasis. Also was sclerotic as well. Yeah. So we in Perth and the Royal Brisbane did a study where we compared gallium PSMA 11 to 1007. And it came out that there were too many bone lesions for us to use it clinically. So there are certain scenarios where it is quite useful. In very early stage disease, because you have no bladder uptake, and you really want to have a good look at the prostate, or in early recurrent disease, biochemical recurrence, you may get early pickup. But then if you start seeing one or two bone lesions, then it can make it more difficult to report.
Thank you, bro.
Is there any question for Professor Natlenzo from the audience? No, if not, I have one question. Do you always mention in your report the physiological findings, like or another unrelated findings?
So so in Australia, there are two major ways of reporting. There is what I call the radiologist way, where they talk about tumour, nodes, hematology spread, and then they have a section called incidental findings. So they don't often talk about physiological activity or anything like that in that reporting. Talk about your primary tumour, then you talk about nodal staging. It's basically almost like a TNM way of reporting. It's not the way I report. It's not the way I report. I report by anatomical location. You know, what's in the head and neck, what's in the thorax, what's in the abdomen and pelvis, what's in the musculoskeletal and other. We talk about relevant physiological activity. So, you know, physiological activity is normal in the brain. It's normal in the oropharynx. So we talk about that, but we don't want to go too much in depth and give a 5-page report. So relevant physiology, things are normal in the liver, spleen, kidneys, adrenals, small bowel. So one line. So we don't often go, but if we see an abnormal anatomical issue, gallstones or something, then we will make a mention of it. If we see coronary calcification, we make a mention of it. So we do mention what we consider to be clinically relevant anatomical findings, but we do structure the report to try and answer the clinician's question. Why have they asked the question? So what we try and teach our trainees is, what is the question? And if you can't really understand what the question is, contact the referrer. Give them a call. Say, what do you really want to know? Because in the end, the referrers, clinicians are busy. They want an answer, and they want it nice, relatively brief. Not too brief where you don't give them any information, but brief enough that they can read it relatively quickly. So, you know, we try and tell our clinicians, 1-page report. 1 page, structured, important findings, answer the clinical question. That's doing your job.
Okay. Thank you, Prof, for your insights. So please give applause to Professor Natlenzo. And if you need more advice or suggestion, you can find him in Bali. Okay, so we go to the next expert. Oh. Okay, take your time, please. Okay, so we go to the next.
Okay, let's start. I think we have an hour to discuss some cases, and I think just 2 or 3 comments to the presentation from Professor Natlenzo. First of all, the UBUs, that's why you refer to, the unspecified bone uptake, it's quite often seen in PSMA 1007. So be aware that the incidence of UBUs is much higher compared to the other PSMA tracers, but also in the other ones they are observed. But what we know from the PSMA 1007 is that you quite often see them in the pelvis and the lumbar spine. A second thing is that some people think that PSMA is a specific tracer. It is not. PSMA is not. It is prostate-specific membrane antigen, but there are other topics or diseases that show PSMA uptake. Think about inflammatory lymph nodes in the pelvis. Sometimes you see some faint uptake in the pelvis, and when the tumor is localized at the other side in the prostatic gland, well, be very aware that the lymph node at the other side, it can be metastatic disease, but it can be also just a reactive lymph node. Be aware of that. And also fractures. When a patient has a fracture somewhere, you get also PSMA uptake because of neovascularization. That is in fact the explanation for non-specific uptake. Now, we are in Amsterdam doing a study on the differentiation between radiation necrosis in the brain and tumor recurrence, irrespective of the tumor type, but we study it now in breast cancer, lung cancer, and melanoma. And most of the patients die from metastatic disease in the brain. And these patients are treated with a high-dose radiotherapy. And usually it goes quite well. But at a certain time point, it is very difficult to differentiate between tumor progression or radiation necrosis or whatever. And what we are now studying is we do a PSMA scan of the head and neck region. If there is faint uptake with an irregular distribution, it's quite often radiation necrosis. And if you have intense uptake in a more round-shaped area, it turned out to be metastatic regrowth. So hopefully we publish it at the end of this year. But if that is true, we overcome the problems that MRI has. They can never differentiate properly between radiation necrosis, or not always between radiation necrosis and tumor recurrence. So hopefully, if that is true, PSMA gets another indication, and that means differentiation of brain abnormalities. But just to clarify that PSMA is not as specific as it is, well, supposed to be. Okay, well, that's just the beginning of the end of the PSMA story. Now we go to the FDG PET scan, and I show you some slides. I think it's important to start with. Like Nat Lenzo mentioned, the normal distribution of PSMA. You have to realize that the FDG PET scan has also a normal distribution. And we heard this morning how to make a report. I think as in Australia, but also in our country, if there is a normal physiological pattern, it's just one sentence. We see physiological uptake in the brains, myocardium, liver, spleen, and normal excretion from the kidneys into the bladder. And I think it avoids a 5-page report for the clinician. So if you see something like that, with a normal distribution pattern, you can describe the head and neck region. We see normal uptake in the brains, in the tonsilla, in the liver, when you go down. But you can also say it's normal. This is the normal pattern you see. And that makes it quite comfortable also for the clinician. And I agree fully that the clinician wants an answer to the question, is it cancer or not? And if it's cancer, where is it localized? And that's it. And if you find abnormalities, then put it into your report. And it is either FDG FIT or an abnormality on the CT scan, but you have to mention that. And also in your conclusion, you start with answering the question, and then you go to the additional findings or the incidentalloma. So be aware, this is normal, but you don't have to report every normal uptake. There are some factors affecting the PET scans. You have to realize that the tumor uptake can be influenced, FDG uptake in the tumor can be influenced by several factors. The first one are the patient-related factors like glucose levels. Has the patient diabetes or not? And the higher the glucose level, the lower the uptake will be in the tumor. Insulin use, metformin, corticosteroids, they absolutely influence the uptake in the tumors. What is your recommendation when a patient is on metformin? Who dares? Nobody dares. Who will stop the metformin?
No need to stop. At least unless you use contrast, you need to stop for 2 days.
That's right. So metformin, continue it, don't stop it unless the tumor is localized in the bowel. Then you want to get an idea. And then that might be an indication to stop metformin. But why don't we stop metformin? Yeah, another problem is that if you stop metformin, the patient is out of control for several days. That's completely different from insulin. So usually when a patient is on metformin, you can continue it and that's it. Leave it. Don't do anything with that unless. What about insulin? Who wants to stop it? Insulin? Raise your hand. So you accept that the patient gets insulin 2 hours prior to the PET scan.
Short-acting insulin. If they use short-acting, then you need to stop at least 4 hours before injection.
Yeah, so be aware that if a patient really is under control with insulin, what you can recommend is give him a minimal amount of insulin and some food to avoid that he gets into disbalance, if that's acceptable. But if you stop insulin, you may get into problems in a short time, depending, of course, on the long-acting or the short-acting. But think about it. Don't continue it. Stop it unless. So that's the other way around. So metformin continue until, and insulin stop it unless. That's it. Simple rule. Muscle activity. Usually you see the activity in the chest region. When the patient is dyspnoic, you really observe that. Describe it in your report that the diffuse uptake in the chest is related to, well, and why do you have to report it? Because when the clinician has a look at the FGG scan and says, oh, what's happening in the chest, he will find the answer in the report. That's it. So explain when there is non-physiological uptake also. And also exercise. Sometimes we have bodybuilders who come in with muscles like me. Don't laugh. And you see the muscles here and there and everywhere. And they did some exercise early in the morning. You will find the uptake. So at least 24 hours. Really, when a patient is doing sports every day, he has to stop it the day prior to the PET scan. Of course, tumor-related factors may affect the uptake, like hypoxia. So hypoxia increases the FGG uptake. So that is different from necrosis. In necrosis, there is no uptake, but in hypoxia, it stimulates the uptake in the tumors. And it has something to do with the glucose metabolism. Be aware of that. Of course, blood flow. Any increase of blood flow stimulates the uptake. So any inflammation causes leakage from the bloodstream, an increase of the blood flow, and that causes non-specific uptake at sites of inflammation. And finally, the tumor-related factor, well, the malignancy rate. The higher the malignancy rate, the higher the FGG uptake, the poorer the prognosis is. And especially in tumors that do not show any FGG uptake at all at the beginning, if it starts taking up FGG, there is something happening. You see it sometimes in the low-grade lymphoma, and suddenly they show FGG uptake, and it increases and it increases. And it means that you get a transformation from a more benign to a more aggressive lymphoma type. Finally, treatment-related factors, surgery, recent surgery, interventions, radiotherapy was the question this morning. Wait at least a month. Chemotherapy, immunotherapy, you may get pseudoprogression, also mentioned this morning, or a combination of therapy. So there are so many factors affecting the uptake. What do you see there on the right side? This is an example of brown fat. What to do with it? Does the patient have to come back? So this is a patient with a head and neck tumor. What do you want? Ooh, now you're silent. You all said no, but now the patient has a head and neck tumor. What do you want to do? Redo a scan. Yeah. If this patient had a tumor in his pelvis or somewhere in the bowel, having metastasis at that site is very uncommon. You can leave it. It is not physiological uptake. It is related to cold temperature. It's typical female pattern. And what is brown fat? Who knows? It's uptake in brown fat. That is what you see. You know? What is brown fat? Who dares? You see it sometimes, especially when it's a cold season outside. The clinician asks, okay, brown fat, but what is it? How shall I explain it to the patient? Brown fat is in fact fat that hasn't resolved after delivery. So young children have brown fat, and brown fat is there to produce warmth, heat, energy. So when a baby is getting cold, brown fat is activated to keep the temperature okay. But when we're getting older, it usually resolves over time. So the amount of brown fat should go down. However, apparently women stay younger over time and they keep some brown fat, more than men. So usually you see brown fat in women more often than in men, but it is just, in fact, fat that hasn't resolved, embryonal fat, to keep temperature correct in babies. So now you know what brown fat is. It's quite simple. Not all tumors are FGG avid. And I think you said something about PSMA avidity. PSMA is not related to avidity. PSMA is related to PSMA expression. FGG is related to avidity. So be aware of that. So don't say we see a PSMA avid tumor. Wrong. So there are some tumors clearly FGG positive, like lung cancer, melanoma, bladder cancer, colorectal cancer, the ductal breast cancer types, high-grade lymphoma, and also head and neck tumors. Usually when you do a PET scan, no problem at all. But there are tumor types that in most cases do not have FGG uptake. Adenocarcinoma in the lung. It's like a bit milk in the coffee. So if you put milk in the coffee, you see a bit cloud aspect with minimal FGG uptake. Don't say it is not malignant because the FGG uptake is low. It can be either an adenocarcinoma or a neuroendocrine tumor. So also neuroendocrine tumors, prostate cancer and thyroid cancer are cancer types that generally do not show FGG uptake. So don't use the PET scan for staging these tumor types unless you see dedifferentiation. So the longer a tumor is there, like neuroendocrine tumors or thyroid cancer, the longer you wait, the more it may change into a more aggressive form, the dedifferentiation. And then you see an increase of FGG uptake. Lobular breast cancer is also a tumor type that's quite often missed on the PET scan. And if it is FGG negative, what can you say about metastasis? Who dares to say something about uptake in metastatic disease then? Well, you shouldn't report it. If the primary tumor in the breast does not show any uptake, don't say there are no metastases. You cannot say that. You cannot visualize them because there is no uptake in this subtype. So mention that in your report, that if the FGG uptake in the primary tumor is nil, you can't say anything about lymph node metastasis. Be aware of that. It's a take-home message. Low-grade lymphoma, usually no uptake. And the mucinous tumors and renal cell carcinoma, typical examples of extremely low uptake or no uptake at all. So be aware of that. And again, if there is transformation or dedifferentiation, you see an increase in these tumor types of FGG, it becomes more aggressive, and that means that the prognosis worsens. Well, first things first. If you want to start reading a PET scan, you need every information that is available. And don't just have a look at the PET scan and you say, okay, you see a primary tumor and that's it, fine, thank you. 5-page report, this is normal, that is normal, I see that normal, there's tumor. Don't do that, don't do that. So, again, start with the clinical information. What is current problem? What are the symptoms? Type of treatment so far? Comorbidity, recent trauma, whatever. Go for that information. And if you don't understand what you're looking at, and you don't understand the distribution pattern, go back to the clinician and ask him, her, what has happened so far. Of course, historical information. Is it a primary tumor or a second primary tumor, an unknown primary tumor, whatever, you need that. Interventions in the past, family history, it's all relevant for assessing an FGG PET scan. Pathological information, the tumor type, tumor subtype, I explained to you that it is really important which subtype of breast cancer you're looking at. lobular, or the ductal cancer. Be aware of that and don't say it's breast cancer, so we go ahead. No, ask for that if it's not present in the request form. Molecular information, if known expression, a BRAF tumor is more aggressive than BRAF mutated than a non-BRAF mutated. So ask all the information. It helps you in clarifying what you see. Is there anything known about metastasis? Hematological parameters, biochemical parameters, and tumor markers. If they are available, have a look at it. A patient with a PSA level of 4.5 with a large tumor in the prostatic gland, and you see a lesion somewhere in the skeleton, the risk of metastatic disease is not that high with a PSA level like that. The higher the PSA level, the higher the risk on lymph node metastasis and bone metastasis. So if you say, I see a lesion in the skeleton and it is definitely a metastatic disease with a PSA level extremely low, I'm not so sure whether you're on the right side. Okay, radiological information, all the imaging information is required. And then if it's not clear, go back to the clinician. If the patient is still in your department, go to the patient. Did you have a trauma recently? What happened with you? Did you fall down the stairs? Whatever. Ask for it. And if not possible, call them or ask the family what has happened. Do they have more information? Now, a final comment about the tumor markers. There are a lot of tumor markers available nowadays. We know thyroglobulin, the CEA levels, or whatever. And if you're dealing with a primary tumor that hasn't been treated yet, you have to realize that the tumor marker is just a marker of, well, it says something about how big the tumor is and whether there is a risk of metastatic disease. Thyroglobulin levels should not be tested before surgery. You can do that, but it is better to do it after surgery because then you know what the real value is of an elevated thyroglobulin level. But don't forget that. So all these tumor markers say something about tumor bulk. Okay, what's next? Be clear and concise. So again, don't make too large, big, huge reports. The clinicians will never read it. They are not interested in it, and they say, what are you talking about? Normal brain uptake, myocardium viable. Yeah, that's not relevant unless there is a calcification or there is a focal intense spot. What is it? But be aware of that. If not normal, find the cause. So if you see brown fat activation, mention it in your report. That's important. Just an explanation, and to avoid a phone call by the clinician. What is that in the head and neck region? If normal, mention it as general finding, not for all sites separately. Describe the radiopharmaceutical and the activity administered. Have a look, mention the glucose levels, especially when you do follow-up scans, because they may interfere with the SUV values. Describe the tumor clearly and the metastasis, so the ANM stage. Say something about where is the primary tumor, where do you see the lymph node metastasis, and where the distant metastasis. You can say something about the intensity, heterogeneity, photopenia, quantification of the tumor lesions. You can do that. If you're used to do that, then keep on doing that, but it is not always required. Just for staging, you don't need it. If you want to have a prognostic indicator, then you can quantify it. If you're going to do follow-up scans, so if it is especially in case of therapy follow-up, then it is really, really needed, recommended to do an SUV measurement. So be aware of that. The most reproducible value is the SUL peak. And why the SUL value? What is the difference between the SUL and the SUF? Do you know that? Who dares? Who wants a microphone? The SUF mean is just, you know it, Ivana. I give you the microphone. Explain to your colleagues the difference between the SUL and the SUF. So the SUL is the?
Lean body mass.
Oh, the lean body mass. Okay. And why do you need the lean body mass? In what is the reason that it is more reproducible than? The problem is that if you start with a patient slightly overweighted, the body mass index is usually high. If you start giving the patients chemotherapy or whatever kind of treatment, the patient will lose weight. And the first thing they will lose is fat and muscle activity. So the lean body mass from the beginning on is more, how do you say that, related to the real status of the body than the body mass index. So be aware that if you want to have a more reproducible value over time, that is corrected effect of losing body weight, then the SUL is much better than the SUF. And the peak value, well, that has something to do with the size of the void you use instead of, well, just drawing a region of interest around the tumor. So the SUL peak is the most reproducible value, but in clinical practice, who is using that value? Who is using the SUF max? Most of us. It's easy, convenient, simple. Draw a region and you get your answer. So I think that's it. I lost my pointer. Okay. Some practical aspects. Less is more. Don't describe all normal findings. Keep it simple. Keep your report readable for the clinician. Don't make it too complicated because they will call you. What do you mean by this? What do you mean by that? 5 pages reports are really not read by all the clinicians. And when doubt, call the clinician and mention it in your report that there is doubt about what you see. So don't say it is this or that, or it might be, and you get a list of whatever, but say something about, I'm not really sure what I'm looking at. So either discuss it in an MDT or with your multidisciplinary team, or try to explain it. But be aware that sometimes we are in doubt. And don't say, I don't see anything or whatever. And you may say that there is some doubt. Okay. Rian, are you ready for the case workshop? We prepared 5 cases. It depends on the time. We start with number 1. And I think you need a microphone. What we will do is we start with a presentation of the clinical information. And then you can start patient number 1. Have a look at it. And then we start a discussion. And there's no possibility to leave the room anymore.
Okay, teman-teman.
All now partner in crime. So I will walk around and ask you what you see and what do you think.
Ya, teman-teman bisa lihat di komputer yang di depan kalian ya. Nanti dibuka pasien 1. Sambil nanti kalau ada kesulitan bisa tanya Mas Wahyu atau gimana cara bukanya. Ini di depan juga ada monitor, bisa ikutin yang.
Okay. So start with patient number 1. And we start with the clinical information. If you're, hopefully this is not your clinical practice that you start reading the PET scan. You need the clinical information.
Oke, sekalian nanti praktek viewernya dari UI, nanti bisa sekalian dibuka gambarnya. Jadi ini seorang wanita 40 tahun dengan unknown primary with metastasis intraabdomen. Pasien mengalami nyeri perut dan konstipasi sejak 3 hari sebelum masuk rumah sakit. Perutnya kembung sejak 3 bulan sebelum masuk rumah sakit. Dari hasil USG abdomen, tampak asites dengan dilatasi intestin, DD-nya enteritis. Biopsi abdomen bulan Oktober 2024, hasilnya poor differentiated adenocarcinoma metastasis.
So you know that there is a big problem in the abdomen. They are looking for a primary tumor and they ask for a PET scan. Now, before you start reading the PET scan, you have your knowledge about the value of your PET scan for this indication. How often do you find a primary tumor when they ask for it? We cannot find it on CT or MRI or whatever. We want a PET scan. And how often is a PET scan helpful? How many cases? What is the percentage?
20 to 30.
Yeah, it's around 25 to 30%. And it means that you know prior to your reading, you will miss 70% of the cases. Be aware of that and discuss that with your clinicians.
Sambil dibuka gambarnya ya, sambil dicari di mana primernya.
Yeah, you can see the not normal uptake.
You can see the not normal uptake. So what is the definition of a high quality PET-CT scan?
See the distribution of the radiopharmaca distributed in all normal organs that should be uptake.
Okay, so you expect a normal distribution pattern with FGG uptake in the brains, and sometimes in the myocardium, and some faint uptake in the liver and spleen. If the uptake in the brains is extremely low, it can be either a quality problem, but usually when you see a pattern like this with diffuse uptake in the abdomen and faint uptake in the brains, it has really a poor prognostic value. And usually when you see that, the patient will die within a couple of days, because that means that there is brain dysfunction. Be aware of that. So don't always say, oh, it's just a technical problem. If you see intense uptake in the tumor and minimal uptake in the brains, there is something wrong with the patient, really wrong. So be aware of that. Okay, who wants to tell us what he or she, I think you are really good. What did you see?
I see.
If you want to sing it, Pusha.
I see. I don't know, Prof.
The most important question is, you see diffuse uptake in the abdomen.
Can we show the result to them?
Yeah. So if you go down to the PET scan, we give you a clue, and it means that this patient had diffuse uptake in the abdomen, and it means that there was metastatic spread all over the abdomen. Be aware, this is really, really pathological disease. Micrometastasis can be missed on the PET scan, but this is really a drama. Now the question is, do you see somewhere in the body, you know it's an adenocarcinoma, it's a woman. So if you talk about an adenocarcinoma, the first site, when you look at distribution pattern like this, where is the primary tumor quite often located? Ovaries. So be aware of that. The silent killers, they call it. Huge abdominal mass, fluid, ascites. And if you find that, the first thing to look for is what happened with the ovaries, especially when it is adenocarcinoma. In women, when you're looking for a primary tumor site, there are in fact 4 or 5 sites which you have to check. The thyroid gland, breast tissue, lung, ovary. And then in most of the time, most of the cases, you will find the primary tumor. So be aware of that. In men, Well, you start also with the thyroid gland, nasopharyngeal region, especially when you talk about smokers, you're dealing with smokers, so be aware of that. So if you're looking for a primary tumor site and you know it's adenocarcinoma, start with especially the ovaries in women. Well, Rian, what did we find? Maybe you can show it.
The pathology result is high-grade serous carcinoma of ovary.
Yeah, so the pattern, the distribution pattern is in fact like that, like ovarian cancer. And you see intense uptake at that site. And there is really diffuse metastatic spread in the abdomen. And what is the prognosis of a tumor like that? Poor. Yeah, the prognosis is not so good. So they have to start with chemotherapy and hopefully it works. But you see here, she received 5 cycles of chemotherapy, no complaint of abdominal pain, and to my knowledge, she's still alive. Yes?
Metabolic in the primary, but the metastasis have the high hypermetabolic. Why the primary have no metabolic lesion, but the metastasis have hypermetabolic?
You think when the primary tumor has no uptake? Yeah. No, but there are masses in the ovaries. But if there is no primary tumor visualized on the PET scan, then it remains an unknown primary tumor, and the prognosis of an unknown primary tumor is much worse than when you find a primary lesion. So be aware of that. That is really important, why you have to do a PET scan to find the lesion. It's also in head and neck cancer when patients present with lesions in the head and neck region and there is no primary tumor. What they will do is give chemotherapy, radiation on the whole head and neck area. But if you find a primary lesion, you can really spot it. Then the treatment is more focused on the tumor instead of a diffuse general treatment. So that is why we do a PET scan. Okay, shall we go to the next case?
Yes.
But sometimes you find also in women an incidentaloma in the thyroid gland. What should we do with that? What, Fabi?
Follow up with ultrasound.
Follow up with ultrasound. Why?
The first imaging for thyroid, I think, is ultrasound and PHH lab.
Okay, so if you find a nodule in the thyroid gland, go for it, because the risk on thyroid cancer is around 25%, irrespective of the uptake. So don't say, oh, there is minimal uptake, neglect it. If there is uptake in the thyroid nodule, do an ultrasonography and fine needle. Yeah. The risk of finding a nodule in the thyroid gland is around 4%, but if you find it, the risk on cancer is 25%. Okay, next case.
Ya, ini pasien perbandingan sebenarnya. Jadi dibandingin sama apa sebelum dan sesudah terapi. 55 tahun, seorang wanita dengan kanker pankreas, riwayat kanker payudara kiri. Dari anamnesa, pasien sudah menjalani mastektomi sebelah kiri, payudara kiri tahun 2020. Pankreatektomi 3/4 2021, sudah kemoterapi 2022 dan tidak ada keluhan. Mungkin yang nggak bisa buka di komputer bisa lihat monitor di depan.
5 minutes to assess the PET scan.
Oh, oke. Yang bisa buka, jangan lupa diklik follow up studi.
So this patient has already had therapy for breast cancer and for pancreatic cancer. And the question is, what is the current status of this patient?
The therapy response.
It's in fact a response evaluation.
Okay. Which one is the new one? Almost the same. Baseline. The baseline. Which one's the baseline? Upper or lower?
This one. The upper one. Okay, are you ready for the reading? We start with one expert. We take the upper row. So this patient has been treated for breast cancer. And the question is, what do you see? Well, what is this, what you see here? The intense uptake there. In the head and neck region.
Oh, yeah.
What do you think? Is it abnormal?
It's physiological uptake.
Physiological, at where?
Nasofaring. At the nasofaring.
The vocal cords.
Oh.
So be aware, you may observe increased uptake at the vocal cords. That's normal.
Oh, vocal.
The problem, like brown fat, it's more observed in women than in men. Because usually women keep on talking. Do I say something wrong? Oh. But usually if you see that, I'm absolutely sure. Quite often when patients, women, keep on talking, are you sure you're right? Well, today I had a good day. And then, yes, the sun is shining up. And then you get increased uptake. You see, and that's the strange thing, breast cancer was at the left side. You see the post-treatment options. Now you see some uptake there in that area.
Yeah.
If a patient is operated at the left side, at what side do you have to do the injection? At FGG.
Right side.
Right side. Why? Why?
For the obstruction.
I heard 7 things, but the answer is clear. If there is extravasation, you get uptake, a kind of sentinel node procedure in the axilla, and you get false positive results at that side. So that is the reason why you do always at the other side the injection. Now sometimes they say, well, there is some uptake there might be a lymph node. Surgery was done at the left side. Is that metastatic disease at the right side? In the axilla. The problem is, it can be reactive, but usually after surgery, you get a different lymph drainage pattern. So be aware that if you see something at the contralateral side, you have to mention it in your report and don't describe it as it can be something normal or physiological or whatever. So be aware that after surgery, at one side you get drainage patterns that are completely different from the normal situation. So if you see a lymph node, there was a lymph node, wasn't it? I'm not sure. Oh, you cannot control. Yeah, but at least mention it in your report, and if there is doubt, they have to check it. They have to take a biopsy. Well, you see the normal distribution pattern, brains, excretion from the kidneys. You see some uptake here in the bowel. This patient may use metformin. Be aware of that. But in fact, the pancreatic region is completely normal. So no signs of lymph nodes, no recurrent disease, no metastasis in the bone. Now this patient has breast cancer, has had breast cancer. Does this patient have an increased risk on thyroid cancer or not? Why? Why does this patient have an increased risk on thyroid cancer?
Related to the genetic P10 genetic.
Can you say that again? Because I think, yeah?
Because of the genetic P10.
Yeah.
Like
They may share the same genetic abnormalities. So if a woman has had breast cancer, the risk on thyroid cancer is slightly increased, and also the other way around. A woman with thyroid cancer has a slightly increased risk on breast cancer. Be aware of that and check these organs. Well, you see here, I'm not sure, I think there are some lymph nodes there. Yeah, the report.
Complete metabolic response. So there is no suspicious for recurrency at surgical field, nor in the left breast or in the pancreas. So the complete metabolic response.
So sometimes a PET scan is normal, and if you don't find it, keep on looking. And if there is doubt, mention it in your report. There is some doubt about something I see, I do not understand, describe it. But when it is normal, and you're really sure that's normal, say the PET scan is normal. Just one sentence in your conclusion. No signs of abnormalities. That's it. And leave it as it is, and don't start describing again in your conclusion what you have already mentioned in your report. Quite simple. Okay, shall we do a third case?
Oh, question?
There is a question.
Back corner.
Style of the conclusions. So there is different with we say still no hypermetabolic or no hypermetabolic. So it's different.
but what is your?
Yes, in this result, they say that still no hypermetabolic lesion. So it's there is different with. We say still no hypermetabolic, or just say no hypermetabolic. It's different, or
Yeah, I'm not so sure whether I would have used words like this.
Yes.
I think that if you are really sure, you can also say we don't have signs of metabolic disease, metastasis, and that's it. And that means you know that it was an FGG-avid tumor. Or you can say something, there are no FGG-avid lesions on the PET scan, and then you're there. So hypermetabolic, yeah, then the question is, are there non-hypermetabolic lesions?
So
that's what our clinicians ask. Did you see abnormalities that are not hypermetabolic? So be concisive and say, we did not find any abnormalities or no FGG-avid lesions and no other findings on the PET scan, and that's it. And then you have in one or two sentences your conclusion. Okay.
Okay. If I can translate, still no hypermetabolic lesion means that masih tidak tampak. Jadi kalau dibandingkan kita dengan kalimat perbandingan, jadi masih tidak tampak atau tetap tidak tampak. Kalau tidak ada perbandingan, kita langsung bilang no hypermetabolic or tidak tampak. It's just a sentence. Okay, one last case.
One last case. Just one comment on your question. How should you describe it? I think what you should do is teach the clinicians how to read your reports. And take them by the hand and say, okay, this is what I mean. And during your MDTs, you should explain your PET scan. There are no abnormalities, no suspicions on recurrent cancer. And that's it. So hopefully during the MDTs you can explain or elaborate a bit on that, but keep it still concise if it. I mean, don't make it too long, your explanation. But take them by the hand, the clinicians. Okay, the final case. Multiple lung nodules, suspect for malignancy. The patient is a heavy smoker, recurrent cough. He has a history of herpes zoster, so a viral infection, rashes at the back of the right breast, history of schizophrenia. Does it influence the PET scan? The only thing you may be worried about is whether the patient can lie still during the PET scan or not, or during the administration of the FGG. So be aware that sometimes patients are really anxious or, well, have problems like this, and it may completely affect the quality of your PET scan. Be aware of that. No complaint of pain, and then we have the PET scan here. Well, good luck, have a look at it. You see uptake there in the arm, uptake there in the head and neck region. Well, doesn't look too good. So what do we see here? There are some densities. You see increased uptake. It looks a bit like lymph nodes in the head and neck region. What can it be? For the lesions in the head and neck regions, there are 2 or 3 explanations. The first one is, can it be a lymphoma with intense uptake? When we discussed this case, it was my first suggestion. I said, this is really strange. And how do you explain then a lesion in the upper arm? Well, sometimes you have the extranodular lymphoma depositions, which can be located either in muscles or skeleton or whatever. So it was, in fact, our first impression. A second cause can be, with intense uptake in the head and neck region, a primary tumor in the head and neck region. And if you see it on the bilateral side, it's usually a sign of aggressive head and neck cancer, especially in men who smoke. Look at the nasopharyngeal area. So be aware that tumors like that can spread everywhere and are really aggressive. And the prognosis of a nasopharyngeal tumor is usually not as good as other tumor types in the head and neck region. So, or with respect to the localization. Okay, then we have the lesion in the upper arm. Well, it can be a sign of lymphoma, but it was really difficult. So we went back to the clinician. We did, because we didn't understand what was happening. Rian, help us.
Do the biopsy, and pathological results show fibrocollagenous tissue with chronic inflammation. No malignancy.
This is really chronic inflammation. That's really strange. But this patient had a viral infection, a severe viral infection. The patient had complaints. So it can be related all just to inflammatory disease. And that is what I mentioned at the beginning. A PSMA PET scan is non-specific. You find prostate cancer once it is diagnosed and you go for metastatic disease. But PSMA, well, when you are not able to take biopsies, you can do a PSMA PET scan for primary diagnosis, but in general, the diagnosis is already established. If you do a PET scan without a primary tumor, be aware that you find a lot of, well, don't call them false positive. It's another explanation for FGG uptake at sites that can be caused by inflammation, active fibrosis, the benign entities that may also cause FGG uptake. And the reason to present this case, to discuss this one, is that we all thought it was a lymphoma because of the distribution pattern, but we discussed the lesion in the upper arm. Maybe you can remember that, and I said, well, what's happening there? well, it turned out to be all inflammation, chronic inflammation, severe chronic inflammation. And yeah, that's it. So sometimes if you don't understand it, go back, advise them to do a biopsy. And normally when you do an FDG PET scan, don't do it just without any information about the primary tumor, because you get results you do not understand. So in fact, the primary tumor should be known, then do the PET scan, and then you can help the clinician. If you help them the other way around, you have a PET scan and you are going to tell the clinician, oh, I don't know what it is, then you have a problem. And that is not in fact the clinical practice we should do in the hospitals. It makes it very complicated. So the clinician help them prior to the PET scan and tell them first the biopsy and then the PET scan, and not the other way around. The only indication is when they have done everything but cannot find the primary tumor, so we're dealing with an unknown primary tumor, then the PET scan will help you in 30% of the cases. But still then, even 70% of the cases, it doesn't help at all. And be aware of that, and also explain that to the clinician, that primary tumors are either too small, have already resolved in the meanwhile, whatever, but that can make it very complicated. So, malignancy, active fibrosis, inflammation, there are so many causes of FGG uptake. Be aware of that, and you see FGG is really, really non-specific unless you know the diagnosis that it is cancer. And then it is very, very helpful in tumor staging. Okay, I think this was the last case. You must be tired. It's the end of the day.
Yes.
Okay, ready.
Thank you so much, Professor Marcel Stockel. Please give applause. Okay, so because of the technical problem with your PC computer, we cannot open the patient image so smoothly, so we will skip the last session about how to practice to make the standardized report. But maybe if you have time, you can practice in your own hospital. And if you have some problem or trouble, you can call Professor Stockel in Siloam, right? Okay, so I think this is the end of our workshop today. Thank you so much. Thank you for your active participation, and also thank you to Unite Imaging Indonesian Healthcare, right? The name is correct. Thank you so much for providing us the and support this workshop. And I hope the lectures, the knowledge that shared today from the very the best expert in the world can be useful in your daily practice. And after this, we will have a hospital tour. Siapa yang mau ikut hospital tour? Siapa yang mau lihat istananya Sultan Samarinda? Okay. Yes. Terima kasih semuanya teman-teman. Kita persiapan hospital tour ya. Setelah itu kita lanjut balik ke hotel. Thank you so much.